This conference will now be recorded.
All right, so we're going to cover Chapter 18, the Gastro, Intestinal, and Neurologic Emergencies. We're going to be following the National EMS Standard Competencies, and then going more in depth on the abdominal and gastrointestinal disorders, looking at A&P presentations and management of shock associated with abdominal emergencies, gastrointestinal bleeding or GI bleeds, which we do get quite often. We get calls for those type as well. Let's put my phone on vibrate so I don't interrupt anybody. We're also going to cover the A&P and pathophys in regards to acute and chronic gastrointestinal hemorrhage, peritonitis, and ulcerative diseases as well. And then the genitourinary renal as well, looking at blood pressure assessment, hemodialysis patients. Depending on where you work, you might deal a lot with dialysis patients. We're starting to see a lot more home dialysis than anything else lately. Obviously, with COVID and everything else, people coming into the homes together versus going to centers. And then it just makes it easier for someone to be able to sit in their own chair at home and get dialyzed versus actually going to a facility for 6-7 hours a day, 3 days a week. We're also going to cover complications related to the renal dialysis, urinary catheter management, not insertion. We do not insert urinary catheters in the field, and also kidney stones as well. All right, so let's talk about abdominal pain. Abdominal pain is a very common complaint, but also very vague. There's so many things that can go wrong in your stomach that it's often very difficult to identify. So as an EMT, you do not need to determine the exact cause of the abdominal pain. Just be able to, as you recognize, or be able to recognize a life-threatening problem and be able to act swiftly in response to be able to treat that problem. Whether that be calling for ALS for pain management or recognizing the patient might be going into shock based on some type of internal bleed or things like that. The patient's pain is probably anxious, requiring application of your skills of rapid assessment and emotional support. Abdominal pain, it can be from like a gastroenteritis to kidney stones to a AAA to, there's a lot of things that it could potentially be that could be causing these types of pains. So we got to make sure that we're paying attention to our assessment, understand where our organs are located within the thoracic cavity, as well as the abdominal cavity, and understand where stuff is located so we can be able to palpate and say, hey, maybe if we're palpating in the right lower quadrant, they have rebound tenderness, maybe it's appendicitis, especially if they have a fever to associate with that at times as well. The abdominal cavity contains the gastrointestinal system. With that, also has the genital system, urinary system. It contains solid and hollow organs that make up those three types of systems that are there. So we have to understand, like when we're palpating, which organs could be hollow versus solid, and able to, the solid organs, obviously they bleed very, very heavily if there's a damage inside the system. So we got to be able to pick up on those as part of our assessment, especially where the pain is located. Let's go over some of the solid organs, though. So some of the solid organs, or the unique solid organs within our system, are the liver, the spleen, the pancreas, the kidneys, and ovaries in women. So again, like I mentioned before, injury to a solid organ can cause shock and significant bleeding internally. So having an idea of where your spleen is located, your kidney is located, your retroperitoneal, your pancreas, your liver, and when we're doing our assessments, be able to understand where those are located to be able to come up with a more definitive treatment plan. The hollow organs would be the gallbladder, the stomach, the small and large intestines, and the urinary bladder. So if there is a perforation of these hollow organs, the contents will leak and contaminate the abdominal cavity. Versus a solid organ that's not going to leak contents, it's going to leak blood. If there's an injury, it could bleed out. In the hollow organ, we have stuff that's in your acids and feces that are going to get out into the abdominal cavity, causing significant infection. So the next slide, I'm going to show you guys exactly where these organs are located. So obviously this is opposite what you're looking at the screen. So the patient you're looking at here with the organs, your left will be their right. So the liver is located underneath the rib cage on the right-hand side. So when you're doing an assessment, the best way to palpate the liver is put your hands around the rib cage underneath the breast, have them take a deep breath in. On exhalation, you can wrap your fingers around the rib cage and actually palpate the liver. You should be able to feel about 2-ish or so centimeters of the liver. If you feel more than that, usually it's an inflammation of some sort. Your kidney is located just below the liver. Remember that the 4 quadrants are designed based on the umbilical. So where the belly button is located, that's where you draw your X. I'm sorry, your T, and you can separate that into 4 different quadrants. The kidneys are located retroperitoneal, so when you're palpating for kidney stones or pain, you want to palpate on the back side, and we're going to push the retroperitoneal space. Our pancreas is more centrally located, going over more towards the left in the upper quadrant. The ovary is obviously down in the lower quadrants for females. And then one thing that they do not have on here is the appendix, which would be located in the right lower quadrant. As far as some of our hollow organs go, obviously we have our gallbladder, and that can actually mimic a heart attack. You can still have that pain and discomfort, and it'll actually radiate up through your sternum. It's kind of like a burning sensation. People usually think they're having a heart attack. Well, really, it's a gallbladder issue with acid buildup. So again, don't rule it out. It still potentially could be a heart attack. We don't know until we get labs and then EKGs and everything else. Other ones would be the stomach. In patients going into shock, one of the first organs to start shutting down is going to be the stomach. So if that's the case, then treatment for this is going to be obviously getting fluids if they're in shock, giving antiemetics like Zofran for the advanced EMT or paramedic level is really not going to do much for them. Large intestines, small intestines, uterus, urinary bladder, as you can see what those are located in the fallopian tube as well for females. So the gastrointestinal system is responsible for the digestion process. So digestion begins when the food is put into the mouth and is chewed, and then what happens is the saliva glands secrete saliva and begin to break that food down. Food is then swallowed and then travels down the esophagus into the stomach. The stomach is the main organ of the digestive system. It has gastric juices within the stomach that helps break down the food even more. Switch over. There we go. The liver assists with digestion, and what's happening is it starts secreting bile, which then aids in the digestion of the fats that are there. Also, we have some filters that, as well, in the liver that filter toxic substances produced by digestion. It also creates glucose stores, which are very important for us in regards to breaking down and use of energy as well. Produces substance necessary for blood clotting and immune infection. And the gallbladder is the reservoir for that bile. So what's happening is the liver is secreting all this bile, and it's being stored in the gallbladder to help break down all these substances. Excuse me. So food that travels into the small intestines, which consists of 3 different sections. And I'm pretty sure you're going to see this again. Hint. The duodenum, where my goodness, I can't speak this morning. Digestive juices from the pancreas and liver, that's where they mix together. Then the pancreas then secretes an enzyme that breaks down the starches, the fats, and the proteins. The pancreas then also releases amylase, which is responsible for the breakdown of starches into sugar. Then we have bicarbonate, which is also produced by the pancreas, which neutralizes stomach acid in the duodenum. Insulin is also produced in the pancreas as well, which helps regulate the amount of glucose in the bloodstream. So if people have issues with their pancreas, they can have issues with their blood sugars, which is why they have people are getting insulin and or taking other sugars to help either combat either hypo or hyperglycemia. The jejunum plays a major role in absorption of the digestive products. And does much of the work in the small intestines as well. So 2 parts here. The last part of these small intestines is called the ileum, which absorbs nutrients that were not absorbed earlier and absorbs bile acids so they can be returned to the liver for future use, and vitamin B12 for making nerve cells and red blood cells. So as you can see, it's important to have the liver and the small intestines and everything breaking down so we can secrete the bad stuff and retain the good stuff that's there to help assist us with life. The colon, which is the large intestine, where food not broken down and used moves into the colon as a waste product. So in the small intestines, is breaking stuff down, the good stuff's taken away, the bad stuff is then pushed into the large intestine, and then the colon, where the stuff is not broken down at that point, then moves into the colon as a waste product. Then we have a process called peristalus, which moves the waste through the intestines. Water is then absorbed and stool is then formed. So water passes through the rectum, and water passes through and it's absorbed through osmosis, from osmosis being a liquid, to form that stool. Now, if we have a over-osmotic colon and too much water is coming in to help break down the waste products, that's when diarrhea starts becoming formed. This passes through the rectum into the anus and then is defecated out. That's how we remove that waste product. That's one of the ways we remove waste product. There are other ways as well, carbon dioxide, obviously through breathing, and then urinary as well, which we'll get into in a little bit. The spleen is located in the abdomen, but has really no digestive function at all. The spleen is part of the lymphatic system, which plays a significant role in retention to red blood cells in the immune system. This assists in filtration of blood, aids in development of red blood cells, serves as a blood reservoir, and produces antibodies. So as you can see, the spleen is kind of an important piece to have, especially when we're trying to fight off infection. The genital system, breaking this down, for the male reproductive system, we have the testicles, epididymis, vasa differentia, seminal vesicles, prostate gland, and the penis, male reproductive side. With the female reproductive side, we have the ovaries, fallopian tube, uterus, cervix, and vagina. When we get into OB/GYN, we'll cover more in detail of the female system as well. With the urinary system, controls discharge of certain waste materials filtered from the body by the kidneys, right? That's why it's so important to have our kidneys functioning appropriately. The kidneys are a solid organ, and the ureter's bladder and the urethra are hollow organs. The kidneys there are 2 kidneys, one on each side of the body, which lie posterior muscular wall of the abdomen behind the peritoneum and the retroperitoneal space. That's why when we talk about the assessment, you'll notice in my run reports, I'll put down negative retroperitoneal pain, because that means I'm palpating the back around the backside retroperitoneal space, or the behind the peritoneum, to actually palpate the kidneys and see if there's any increased pain on the assessment. A lot of patients that have kidney stones will have increased pain in the kidney, and the pain will travel with a burning sensation potentially down through the groin. We'll talk more about kidney stones in a few minutes. These play an important part in the regulation of acidity and blood pressure. It also helps rid the body of toxic waste, controls the balance of the fluid and electrolytes within the system, and blood flow is very high to the kidneys. Okay, so again, they can bleed out if you have kidney damage. That can cause significant bleeding in the abdominal cavity. The ureter then joins each kidney to the bladder. I'll show you guys this in the diagram on the next slide. So we have the small hollow muscular tubes, which are the ureters. Peristalus then moves urine into the bladder, and then the urinary bladder is then located immediately behind the pubic symphysis. So when we're palpating the bladder, we want to make sure we're palpating by the lower part of the abdomen. And we can put pressure on there and kind of see if it's distended or not. The male urethra passes from the interior base of the bladder through the penis. Female urethra opens at the front of the vagina. The normal adult forms 1.5 to 2 liters of urine per day. So to kind of break that down, especially if you have a patient who has a Foley catheter in place, the male and female, either way, the adult should be passing about 30 mLs an hour of urine. That should be the average. If you have a Foley catheter in place, you should be able to chart that or note that that they're pushing out about 30 mLs an hour. So here's a picture here of the male reproductive or urinary system. As you can see, the kidneys, then you have the ureter going into the bladder. Urine is now stored there. All right. We have the prostate gland located. So we have a ureter opening. Urine is then pushed out from the bladder once the bladder is full enough to be able to push out fluid. It goes through the urethra to the urethral opening, the external urethral opening, and then urine is now made. All right. Very similar with the female system as well. Similar, not all the same parts, but similar. So some pathophysiology behind this. The abdominal cavity is lined by a membrane called the peritoneum. All right, these are going to be all tests. You guys will see these on the test as well. So the abdominal cavity is lined by a membrane called the peritoneum. The peritoneum also covers the organs of the abdomen as well. The partial peritoneum lines the walls of the abdominal cavity, which is in parietal, sorry, not partial. The visceral peritoneum covers the organs itself. So the parietal peritoneum lines the walls. The visceral peritoneum covers the organ. The presence of the foreign material, blood, pus, bile, pancreatic juice, amniotic fluid, can irritate the peritoneum, causing peritonitis. So again, if there's a foreign material in our cavity that doesn't belong there, it can cause significant irritation and cause peritonitis. So remember, anything that ends in itis, I-T-I-S, means inflammation. So the acute abdomen refers to as a sudden onset of abdominal pain. So if you get called to a patient who develops significant abdominal pains, came on a sudden onset, you would document that as acute abdominal pain. Often associated with severe progressive problems requiring medical attention, whether it be like a peritonitis, which would be like an inflammation of the peritoneum, typically causes the ileus. Talk about here in a second. As you can see, inflammation of the peritoneum. The ileus is paralysis of the muscular contraction that normally propel materials through the intestines. So peritonitis, inflammation of the peritoneum. The retained gas, I should say, in feces cause abdominal distension. Then we're start getting our significant pain. The stomach can empty itself only by vomiting emesis at this point. Peritonitis is frequently associated with nausea, vomiting. So if you have a patient who has peritonitis, they'll have the nausea, vomiting. We want to find a way to relieve that from them. Because vomiting does put a lot of strain on the heart as well. So if we have this, we want calling for ALS care. There's other medications that can be utilized to help stop the vomiting, like metoclopramide or Reglan, or relieve some of the nausea, like ondansetron, Zofran, to be able to assist. Peritonitis is also associated with the loss of bodily fluid into the abdominal cavity. So again, we have an organ that could be damaged, or there's fluid leaking out somewhere where it shouldn't be. The patient may present with tachycardia and hypotension, so look for signs of shock. If there's bleeding in the abdominal cavity, the patients are going to become pretty hypotensive because they have significant bleed. You also want to make sure that you're palpating the abdomen as well, looking for that rigidity. So even if someone's in really good shape, they have abs, okay, as we're palpating, does not mean they're bleeding into their cavity. You'll know when there's blood there because it's very, very solid. There's like no movement. Very hard, rock hard abdomen, significant pain, because now we're introducing a fluid of some sort, whether it be blood or some form of emesis getting inside, causing that significant pain and an inflammation and infection. Diverticulitis is an inflammation in small pockets and weak areas in the muscle walls, and fever may be present with this. Cholecystitis is a gallbladder inflammation, which you may have a fever. And acute appendicitis in the patient's temperature may be within normal limits, but may potentially have a rupture. So again, as you're palpating, diverticulitis, in the diverticulum, you have the small pockets of air located in the intestines. You'll start feeling feel the wall palpating around. People that have diverticulitis or diverticulosis, they know they have a history of it most of the time. So you'll be able to determine the pain from there. Usually they'll tell you, hey, I have diverticulitis as a flare-up. The cholecystitis, gallbladder inflammation, this may require a surgical intervention or removal of the gallbladder if they can't remove the inflammation with antibiotics. And then obviously acute appendicitis is removed. So there are two different types of nerves that supply the peritoneum. The abdominal cavity, the abdominal pain can have different qualities. Stand by 1 second. All right, sorry about that. So the parietal peritoneum is supplied by the same nerves that supply the skin of the abdomen, which then can perceive pain through touch, pressure, heat, cold. It can be easily identified and localized to a point of irritation. They can say, hey, this hurts here. They'll be able to tell you exactly where. The visceral peritoneum is supplied by the autonomic nervous system, where nerves are far less able to localize sensation. Therefore, the patients will not be able to describe exactly where the pain is located. So this is what we call referred pain. And I'll show you guys this in the next slide. So as you can see where the gallbladder is located there, people that are having gallbladder attacks, all right, looking at the synapse points in the gallbladder being located here, as you can see on the screen, you'll start developing that the right shoulder pain up here when they're having gallbladder issues because of the way the nerves are located. The pain travels up and gives you shoulder pain. So this would be an acute cholecystitis referred pain. So it goes to that right shoulder. You guys have any questions so far? We've been at it for about 35 minutes. Doing pretty good? Make sure you're not sleeping this early in the morning after that long exam.
Yeah, we're still good.
All right. Let's keep moving. All right, so ulcers. Ugh, ulcers are horrible. Also, a very one of the questions you'd be asking a patient before you administer aspirin is, do you have any current active ulcers that are bleeding? So the common causes of acute abdomen pain would be ulcers, which are the protective layer of the mucus erodes, allowing acid to eat into the organ. Causes of peptic ulcers would be the Helicobacter pylori infection. Other ones would be like chronic use of non-steroidal anti-inflammatory drugs. So the people that are chronically using NSAIDs, so NSAID being like Motrin, ibuprofen, chronic use of that can cause ulcers as well. Alcohol and smoking, if their erosion is severe, can lead to a gastric bleed. Peltic ulcers also affect men and women equally, but occur more frequently in the geriatric population. So again, geriatric chest pain. Do you have any ulcers? Oh, I do. Are they actively bleeding right now? No. Okay, here's some aspirin. If they're actively bleeding, last thing we want to do is give them any kind of antipyretic or platelet aggregator to stop clotting. Or yes. This is described as a burning, gnawing pain in the stomach that subsides or diminishes immediately after eating. Nausea, vomiting, belching, and heartburn are common symptoms. Some ulcers also will heal without intervention as well. Gallstones. So the gallstone or the gallbladder is a storage pouch for digestive juices and waste from the liver. Gallstones may form, and if they are blocking, and if the blockage does not pass, it can lead to severe inflammation of the gallbladder, causing the cholecystitis. Some conditions in which the wall of the gallbladder are inflamed. The gallbladder can then rupture as well in severe cases, which then presents as a constant severe pain in the right upper or mid-abdominal region. It may refer to the right upper back, flank, and shoulder area. So again, something to pick up on. If the gallbladder ruptures in some severe cases, you may have that severe pain right upper quadrant or mid-abdominal region, and may refer to the right upper back, flank, or shoulder area. Symptoms may appear 30 minutes after a fatty meal and at night as well. My computer just froze up. There we go. Welcome back. All right. So people at higher risk for developing cholecystitis, including women, older adults, obese people, and people of Scandinavian or Native American and Hispanic descent. Pancreatitis, inflammation of the pancreas, caused by obstructing gallstone, alcohol abuse, and other diseases. Some signs and symptoms would be a severe pain in the upper left and right quadrant, often radiating to the back. The patient may report the pain is worse after eating, so nausea, vomiting, abdominal distension, tenderness. Sepsis or hemorrhage may occur, so look for fever or tachycardia. Again, if they're bleeding and they become shock-like, you'll see that tachycardia. Potentially, you'll have hopefully blood pressure is be stabilized, but they can change into hypotension as well. Also look for the signs of sepsis, so known infection site with increased respirations, pulse rates. When we start getting more into sepsis treatment, then I will show you guys that more in depth of assessment stuff. Sepsis, sorry, not assessment. Appendicitis is an inflammation or infection of the appendix. Can cause the tissue to die, causing an abscess, peritonitis, or shock. So again, if the patient is having right lower quadrant pain, the one question you want to ask them is, hey, do you still have your appendix? They say yes, then we need to get them seen. They have to go in for a CT of the abdomen. And then from there, they will determine whether or not it's inflamed, and then they go in and remove the appendix. Pain is initially more generalized, dull, and diffuse. It may also center around the umbilical area. The pain later localizes to the right lower quadrant. So again, initial pain, more generalized, dull, and diffuse. Later pain, right lower quadrant. The location of this is called Mcburney's point. So what you would look for is a patient lying down, find the belly button. You go about maybe a quarter of the way down or 3/4 of the way up from the pelvis. And that's Mcburney's point. You press down and you palpate 2 hands as you push in and see if there's any kind of rebound tenderness and pain on palpation. If there is, then it's probably an appendicitis type deal. They need to at least go in there and get antibiotics to treat. If the appendix does rupture, that's when all the contents leaks out into the system, causing some more issues. With more inflammation and sepsis. All right. All right, so esophagitis. So esophagitis occurs when the lining of the esophagus becomes inflamed by infection or acids from the stomach. So gastroesophageal reflux disease, or GERD, is a condition in which the sphincter between the esophagus and the stomach opens, allowing stomach acid to move up into the esophagus. Also referred to as acid reflux disease. This can cause a burning sensation within the chest and heartburn. So again, if someone has GERD and they eat something acidic, it may cause that pain, or spicy foods. And if that's the case, they may go, oh my God, my chest is killing me, and they start pushing on their chest like it's a heart attack when it's really not. So again, I'm not saying rule it out. That's not part of your job. You still treat it. But ask when they have a history of gastric reflux or GERD. The patient may also report pain and swallowing as well. So other additional symptoms would be heartburn, nausea, vomiting, and sores in the mouth. The next one we're going to talk about is esophageal varices. So this is it can look like a bloodbath if somebody got murdered. It can be very, very bloody. So this occurs when the amount of pressure within the blood vessels surrounding the esophagus increases. So when blood flow is blocked in the portal vessels then dilate, causing capillary network of the esophagus to begin leaking. If pressure continues to build, the vessel walls may fail, causing a massive upper gastrointestinal GI bleed and vomiting blood as well. Initial patient signs and symptoms: patients show signs of liver disease, fatigue, weight loss, jaundice, anorexia, edema in the abdomen, abdominal pain, nausea, vomiting. With that, a gradual disease process. Can take years before the patient feels discomfort. Ruptures of varices is far more sudden versus someone with liver disease. Rupture of a varice would be sudden onset of discomfort in the throat, severe difficulty swallowing, vomiting of bright red blood, hypotension, and signs of shock. Patients that have varice ruptures can bleed out quickly. This needs aggressive airway management. So calling for ALS, getting ALS on board so they can get an intubation tube in place to protect that airway the best they possibly can. Very, very dangerous. Again, they can bleed out in front of you. So just something to think about when you see this. And literally, it's bright red blood like all over the place. Vomiting blood. It literally looks like someone got stabbed or shot when you walk into a home with it. All right, so the next one is Weiss syndrome, which is a junction between the esophagus and the stomach, tears, causing severe bleeding and possible death. Primary risk factors would be alcoholism, eating disorders, prevalent in older adults and older children. Vomiting is the principal symptom, if you see this. So in extreme cases, patients may experience signs and symptoms of shock, upper abdominal pain, vomiting of blood, and then blood in the stools. Gastroenteritis, which is a very common diagnosis, especially in the ERs, you're going for abdominal pain, is an inflammation of the gastrointestinal tract. So infection combined with diarrhea, nausea, and vomiting. So if someone comes in with diarrhea, nausea, and vomiting, a lot of times you'll get diagnosed with gastroenteritis. They'll send you home with some antibiotics, things will go away. This is caused by bacterial or viral organisms that enter the body through contaminated food or water. This can also be caused by non-infectious conditions such as an adverse medication reaction, toxin exposure, or chemotherapy. So diarrhea is the principal symptom in both types. So signs and symptoms would be large dumping type diarrhea or frequent small liquid stools, diarrhea containing blood or pus, abdominal cramping, nausea, vomiting, fever, anorexia. All right, so some causes of acute abdominal. So we talked about diverticulitis already. First recognized around 1900 when the amount of processed foods eaten increased. The consistency of stools became more solid, requiring more intestinal contractions, increasing pressure in the colon. Bulges in the colonic walls result from increased intestinal contractions. Fecal matter then is caught in the bulges that are there, and bacteria starts to gather as well, causing inflammation and infection. The main symptoms would be abdominal pain on the left side or lower abdomen, and other signs you'll see would be fever, malaise, or body aches. Other ones would be chills, nausea, vomiting as well. All right, so hemorrhoids. Hemorrhoids are created by swelling and inflammation of the blood vessels surrounding the rectum. This may result from conditions that increase pressure on the rectum or irritation of the rectum itself. So increased pressure may be caused by pregnancy, straining of a stool, or chronic constipation. So patients that are on narcotics all the time may become chronically constipated, which therefore can develop hemorrhoids. So if you have a patient that hasn't gone to the bathroom in a while, ask them, are you on a lot of antibiotics right now? Are you taking pain medications all the time? All right. Chronic narcotics can cause significant constipation as well. So just keep that in mind. They present as bright red blood during defecation. There's minimal bleeding, usually pretty easy to control, and patients may also experience itching as well as a small mass on the rectum. Now, I'm not asking you to go down and inspect and see if they have hemorrhoids or not. That's what the physicians do. If they have them, just ask, hey, do you have a history of hemorrhoids? You want some blood? Transport them to the hospital if they want to go. Let the physician take care of that. I'm not asking you to go down there and start checking the sphincter. All right. Hopefully, that made somebody laugh a little bit. All right. So cystitis is a bladder infection, which is very common. We get a lot of bladder infections, also called the urinary tract infection. Urinary tract infections are more common in females than in males due to the length of the urethra and the ability of infection getting in. You also have a higher chance as well of urinary tract infections in males that are uncircumcised versus circumcised males. because they're just not getting cleaned as appropriate, not open up the air to let it fight or kill off the infection or any kind of bacteria, I should say, it's there. So this is caused by a bacterial infection. And patients will usually have like a lower quadrant abdominal pain with this as well. And they may report urgency or frequency in urination, so they're peeing more and more often. Another thing as well is you're going to notice is a lot of times there's a foul odor to it as well. So kind of keep that in mind. Some other questions to ask before we get to that. This can become a serious problem if infection spreads to the urethra or kidneys. Questions to be asking: do you have frequent UTIs? Yes or no? And do you home cath? So they may put catheters in at home, and if done in the home, it's really not a very sterile technique, right? When you're putting a catheter in, whether it be a male or female, it's a direct line to your bladder to push infection. It's when placing these, it has to be done with a very aseptic technique, so very clean system. You can't touch anything else when you're putting these in. Yes, especially after having kids. A lot of times kids are very prone to infections, to UTIs as well, especially younger ones. Females, when you're infant child, if you're cleaning, especially a female, and you wipe anus to vagina, all that infection, that feces, everything else can get into that area and cause a UTI as well. So again, it's how you clean. All right, so the kidneys play a major role in maintaining homeostasis. They help eliminate the waste from the blood, and when the kidneys fail, uremia results, which is the waste product urea remains in the blood. So now we have bacteria in the blood, right? Kidney stones then can grow over time, causing a blockage, and it can be very small. What's happening is that we can't push, so that the kidneys will develop calcification, and it blocks the ureters, causing significant pain. All right, it causes irritation. One of the best medications for this is going to be Toradol for what they call renal colic, and it's a high-powered IV NSAID that works really well. So kidney stones can grow over time. It's a crystallized chemical in the urine, causing a blockage and leading to swelling. What's happening is, remember, it's going against the ureter and it keeps touching it, hitting it, causing that irritation. The pain is caused by the stone moving within the ureter as well. So if it gets in there and starts moving through, remember, it's a hard stone scraping up against the walls. A stone may be passed on its own, and usually they tell you to drink plenty of water, and hopefully it'll pass through. But what they'll do, if you go to a hospital and they send you home, they send you a kit to go home with, because they want to catch that stone. So they give you a screen to pee into every time you have to pee, so that way if it does pass, you can catch it and bring it back to the hospital. Acute kidney failure is a sudden decrease in function, which occurs from hemorrhage, dehydration, trauma, shock, sepsis, heart failure, medications, drug abuse, and kidney stones. Right? When your kidney just shuts down. This is reversible with prompt diagnosis and treatment. Now, chronic kidney failure is a little bit different. This is irreversible. Progressive, develops over months and years, often caused by diabetes or hypertension. Kidney tissue then shrinks and function becomes diminished. Eventually, you'll have to go on dialysis, or a transplant is required to remove the waste from the bloodstream. Some symptoms would be altered level of consciousness, seizure, coma, lethargy, nausea, headaches, cramps, and edema in the extremities and face. So for them to check for kidney failure, they're going to send you to a lab and they're going to just check your blood to see if you're in kidney failure or not. And they check a couple different lab values, which we really don't need to get into during this program. The female reproductive organs or the gynecologic problems are common cause of acute abdominal pain. A female in childbearing years that has unexplained abdominal pain potentially could be an ectopic pregnancy. And the most common place for an ectopic pregnancy would be in the fallopian tube. So in chapter 23, which we'll be getting into at some point in time in the near future, gynecologic emergencies covers the gynecologic emergencies more in depth when we get to that. The aorta lies immediately behind the peritoneum. Weak areas can result in abdominal aortic aneurysm, which we call a AAA, which is very difficult to detect. Some of the things you want to do on assessment would be around the umbilical area is palpate if you feel any pulsating masses. Just be very gentle. We don't want that to pop or break open. Remember, that's your aorta. A lot of blood flow coming through, which we discussed in previous lectures. Use extreme caution when trying to assess and detect AAA. Development of an aneurysm is pretty slow. If the aneurysm tears or ruptures, massive hemorrhage may occur. So pain is described as a tearing pain. So if you get to like a motor vehicle accident or if you're at home and someone goes, I have a tearing pain in my stomach, potentially could be a AAA. These patients need surgery right away. Handle the patient gently and during assessment and transport. Even the bumps going down the road has a high potential of causing that to rupture as well. Pneumonia, which is especially in the lower lungs, can cause the ileus and abdominal pain as well. So they have a lower lobe pneumonia that can cause significant pain. All right. Hernias. Excuse me. So a hernia is a protrusion of an organ or tissue through a hole or opening into the body cavity where it does not belong. Hernias can occur as a result of the following: a congenital defect, such as around the umbilicus, a surgical wound that has failed to heal properly, or a natural weakness in the area, such as in the groin. Hernias may not always produce as noticeable masses or lumps. Okay, reducible hernias pose little risk and can be pushed back into the body cavity. Incarcerated hernias cannot be pushed back in and are compressed by the surroundings of body tissue. Strangulation of an incarcerated hernia is a serious medical condition because that cuts off blood supply. So blood supply then becomes compromised by the compressing surrounding tissues that can cause tissue death as well. I apologize. I have a little bit of a head cold, so I keep blowing my nose. So I keep pausing. We apologize for that. All right, so serious hernia signs and symptoms. A formerly reducible mass that is no longer reducible. That means being able to push back in. Pain at the hernia site. Tenderness when the hernia is palpated. Or red or blue skin discoloration over the hernia. That would mean more of the tissue death. Now it's not getting oxygenated. All right, so let's go more about the assessment. So obviously, scene safety, BSI, ensure scene safety, follow standard precautions with a minimum of gloves, eye protection, mask. Consider donning a gown and covering your shoes with disposable protective covers. Remember, GI, blood, vomiting, feces. Last thing you want to do is get that all over you. Determine the number of patients. Consider the need for additional specialized medical resources. Look at the MOI or NOI. Obviously, with acute abdomen can be the result of violence, such as blunt or penetrating trauma. So always be diligent. Right? It could be abdominal injury where they got stabbed, shot, impaled by an object, and things like that. If all that is ruled out and there's no entrance and exit wounds, everything else perfectly fine, and becomes a medical condition, then we can move forward with our assessment. A pale or sweating patient who reports tearing may be having a AAA, so keep that in mind. Gastrointestinal bleeding often has a characteristic odor. It will smell horrible, right? So keep that in mind as well when you're doing your assessment. As far as the primary assessment goes, the first priority is identify life-threatening conditions, assess the patient's level of consciousness, ABCs, rapidly observe the patient in the environment. The patient will often have the knees drawn up to ease the pain of the acute abdomen, so they'll be more like a fetal position. The knees will want to be bent up. So when they're on the stretcher and you say, please put your legs down, I want to buckle your legs in, they want their legs bent for a reason. It's reducing their pain. So then find a way to work around it. Ask the patient about the chief complaint. Why are we here today? Tell me more about your abdomen. If the chief complaint indicates a life-threatening problem, assess and treat that immediately. Airway breathing. Abdominal pain can cause shallow, inadequate respirations. Again, it might not be a respiratory issue, but can cause that shallow respiration. Circulation. Ask the patient about blood in vomit or black tarry stools. And if they had, how long has it been going on for? If you have been vomiting, how much have you vomited? Did you fill an entire trash can? What did you do? Ask those questions. A difference in pulse strength may indicate an aortic dissection as well. Shock may be caused by hypovolemia or the result of a severe infection. If shock is present, intervention should include high flow oxygen, placing the patient supine, and keeping the patient warm. That way they can start treating for shock. Make a transport decision, and if immediate signs of significant illness would be pale, cool, diaphoretic skin, tachycardia, hypotension, altered level of consciousness. You want to make sure that you ensure that the ride is gentle, smooth, and steady. Now, I know we live in New England, so it's going to be tough. Do the best you can. Make sure your driver doesn't turn the lights and sirens on and drive like a bat out of hell to the hospital. That just causes more pain to our patient, all right? If need be, call for ALS and have them come in and give pain management. A lot of times pain management will do wonders for this patient enough to be able to relax them and they'll get to the hospital over these bumpy roads that we have in this state. Remember getting your sample history as well. Other questions you want to be asking and addressing the following areas: nausea, vomiting, any changes in bowel habits. So when was the last time you had a bowel movement? And then if they say, oh, it was about a week ago. Okay, was it hard? Was it solid? Was it soft? Was it diarrhea? You want to know the answers to these questions. Changes in the urination, more frequent, less frequent, smell, odor, color, weight loss, belching and flatulence, pain, concurrent chest pain with that, more like the gallbladder issue we talked about before, and gastric reflux. We're going to do our physical assessment with our secondary. Position of the patient may also give clues of the nature of illness, so position of comfort is key for this. A patient with appendicitis may draw up the right knee versus the left. A patient with pancreatitis may lie curled up on one side. So again, pancreatitis, lie on the side. Appendicitis, right knee up. Physical examinations would be normal abdomen is soft and non-tender to the touch. That's a normal abdomen. Pain and tenderness are the most common symptoms of an acute abdominal pain. So we want to localize the pain. May give us clues to what the problem organ potentially could be, or it could be just a diffuse pain covering the entire abdomen, depending on where it's located. Muscles of the abdominal wall may also become very rigid involuntarily. If that's the case, then we have some free-floating fluid potentially in the abdominal cavity. This board-like muscle spasm is called guarding. So the following steps will help in the assessment. Explain any procedures that you're doing to the patient. Place the patient in a supine position with legs drawn up and flexed at the knees. Expose and visually assess the abdomen. So you need to actually look at it, touch it. Palpate the abdomen very gently. Gently palpate all 4 quadrants of the abdomen to determine softness and guarding. Note whether the pain is localized or widespread. You're going to look for the response after your palpate. So what are they making for facial expressions and things like that? What do they feel like? How do they feel? Ask them. Does the pain get worse when I palpate? Determine whether the patient exhibits any kind of rebound tenderness as well, and we're going to determine whether the patient can relax the abdominal wall on command. Guarding rigidity may be present for this. We're going to check vitals. High respiratory rate with a normal pulse rate and blood pressure may indicate improper ventilations. High respiratory rate and pulse rate with signs of shock may indicate sepsis or hypovolemic shock. If a patient has dialysis shunt in his arm, avoid taking any blood pressure in the same arm as a shunt to avoid damaging it. Okay, they have to go through surgical intervention to put these in, so do not do blood pressures on patients that have shunts or fistulas in that arm. You can go opposite arms perfectly fine, just not in that arm itself. All right, so reassessment, obviously, reassessment is important. Remember, 5 minutes for stable, or unstable, sorry, and 15 minutes for stable patients. Other things to look for in your assessment is, has the patient level of consciousness changed? Is he better, worse? So ask those questions. Alert-oriented ×4, person, place, time, and event. Has the patient become more anxious? They start to become more fidgety. Has the skin signs begun to change? Has the patient gotten better or worse with your treatments? Has bleeding increased or decreased? Is the current treatment improving the patient's condition? Excuse me. Has an already identified problem gotten better or worse? What is the nature of any newly identified problems? At this point, we're going to assess our interventions, including treatments for shock and providing emotional support. Document all this in your narratives, in your run reports. Pre and post treatments, reassessment, assessment, secondary reassessment, document it. Assess interventions, including the following for shock. Transport the patient in the most comfortable position possible, but also keep in mind it has to be legal too, as well. Most patients will want to be supine, so on their back with their knees drawn up. So if a patient wants to lie on his or her side, try to accommodate that position and consider calling for ALS. Remember, they can bring pain meds to kind of help with this. All right. You cannot treat causes of acute abdomen. Take the steps to provide comfort. Treat the patient for shock, even when obvious signs of shock are not apparent. Warm them up, keep them supine. Position patients who are vomiting to maintain a patent airway. If they can't sit up, then turn them on their sides. Right? Contain the vomitus to prevent spread of infections and use a biohazard bag. Use a vomit bag to collect it. The hospital is probably going to want to see the color and what it looks like. Wear gloves, eye protection, gown, and mask if they're vomiting. When the patient has been released to the hospital staff, clean the ambulance. Wash your hands as well. Another trick also for nausea, and it's within your protocol, is having the patient sniff alcohol preps. That usually reduces the nausea at the EMT level. Also, providing low flow oxygen through a nasal cannula can also help decrease nausea and anxiety. All right, dialysis. So in a patient with end-stage renal disease or chronic renal failure, dialysis is really the only definitive treatment. Dialysis filters the blood, cleanses of its toxins, and returns it back to the body. Dialysis eliminates waste, normalizes body chemistry, as well as reduces excess fluid. If the patient misses the dialysis treatment, weakness and pulmonary edema can be the first in a series of conditions that become progressively more serious. Some services transport to and from dialysis centers all day long. So a dialysis machine functions much like normal kidneys do. Patient undergoes long-term hemodialysis, have a shunt that contains a vein and an artery, allowing blood to flow from the body to the dialysis machine. Peritoneal dialysis allows large amounts of dialysis fluid to be infused into and back to the abdominal cavity. Fluid stays in the cavity for 1 to 2 hours and then carries a high risk for peritonitis. Adverse effects for dialysis would be hypotension, muscle cramps, nausea, vomiting, hemorrhage from the access site, and infection from the access site. In the patient's access site, they have a fistula in place and it is bleeding profusely. Please, please do not put a tourniquet on that. It will damage the site. Put pressure on it, put your finger in the hole, and transport. Right? Please do not put, they have special clamps for those, which we do not carry. Right? So you want to make sure that you just apply pressure, but do not put a tourniquet on patients that have fistulas. As far as emergency care goes, manage ABCs, provide high flow oxygen if indicated, manage bleeding from the access site, sitting up in case of pulmonary edema, right? So we want to make sure we're sitting the patient in an upright position that can maintain it to make sure the fluids stay lower into the lungs. If we have pulmonary edema and it starts filling up, that's when we start thinking about using CPAP and other stuff. But the problem is CPAP is contraindicated for hypotension, and we're going to transport promptly. Let's do some review, and then we'll get ready for the next chapter. So the blank lies in the retroperitoneal space. Other than the kidneys, what else would lie retroperitoneal? See a couple on here, a couple of B's. All right, awesome. B it is. All right, number 2. Which of the following is not a solid organ? Which is not a solid organ? All right, nice job, guys. D it is. All right, number 3. A 34-year-old woman with a recent history of pelvic inflammatory disease presents with acute severe abdominal pain. Her abdomen is distended and diffusely tender to palpation. Based on your findings thus far, you should suspect. Hopefully, actually, I'm muted. Most patients with an acute abdomen present with all right, D, tachycardia. So any patient that has significant pain, one of the first things to increase would be the heart rate because they are in pain. So you're going to start seeing that. Also, you'll start seeing increased respirations, which would be called tachypnea as well. Number 5, which of the following signs or symptoms would you least likely to find in a patient with acute abdomen? All right, B. A condition in which a person experiences a loss of appetite. All right, seeing a lot of D's. Awesome. All right, number 7. The medical term for inflammation of the urinary bladder is what? All right, cystitis. Good job. Number 8. If a hernia is increased in the contents, if the hernia is incarcerated and the contents are so greatly compressed that circulation is compromised, the hernia is said to be what? Nice. C it is. Good job. Number 9. A 70-year-old man presents with an acute onset of severe tearing abdominal pain that radiates to his back. His blood pressure 88/66, heart rate of 120, respirations of 26. Treatment of this patient should include what? All right. A it is. Number 10. In which position do most patients with acute abdominal pain prefer to be transported? All right. C it is. Perfect. Let's take 10 minutes. Get up and stretch. I'll see you guys back here at 11:26.
This conference will now be recorded.
Hi, Dave. All right. All right. So, chapter 22, Psychiatric Emergencies. So, applying fundamental knowledge. So, standard competencies of recognition of behaviors that pose a risk to the EMT patient or others. Basic principles of the mental health system. Assessment and management of acute psychosis, suicidal risk, agitated delirium. So EMTs may often care for patients experiencing a behavioral crisis or a psychiatric emergency. With that being said, the crisis may be the result of acute medical conditions, mental illnesses, mind-altering substances, stress, and there are definitely other causes as well. So the myth and reality, right? So at some point, most people experience an emotional crisis of some sort. This does not mean that everyone develops mental illnesses. Otherwise, healthy people may sustain acute or temporary mental health disorders. So don't jump to the conclusion that a patient is mentally ill when exhibiting behavior is discussed in this chapter. So the most common misconception is that if you are feeling bad or depressed, you must be sick. There are many justifiable reasons for feeling depressed: divorce or death of a relative or a friend. So many people believe that individuals with mental health disorders are dangerous, violent, or unmanageable. Dealing with this, with patients like this, working in bigger cities and working rural country stuff as well, obviously working out here where I am now, most of them are not dangerous people. They just want someone to talk to. So only a small percentage of people with mental health problems fall into these categories. So EMTs may be exposed to a higher portion of violent patients because they are seeing people who are, by definition, considered to be having a behavioral crisis versus a psychiatric issue. Many people believe that all individuals with mental health disorders are dangerous or violent or unmanageable. So remember that communication is key. In some cases, patients will de-escalate when a level of trust is established. So again, having that conversation with them, getting on the same page. Don't overpower them, overburden them. Just have a conversation. A lot of times, building a level of trust will help de-escalate the situation. Although you cannot determine what has caused a person's crisis, you may be able to predict whether the person will become violent or not, looking at different body language, the body language, the behaviors that they present. So behavior is what you can see of a person's response to the environment. So his or her actions. Most of the time, people respond to the environment in reasonable ways. Over the years, people have learned to adapt to a variety of situations in daily life, including stress. But sometimes the stress is so great that the normal ways of coping are not enough, or the person uses negative coping mechanisms. Example would be like withdrawal, drugs, alcohol, things like that, to help cope with the current situation. Therefore, it puts them into an area potentially overdosing to um, becoming dependent on other ways to move away the problems. But really, they need just to have somebody talk with them, to work with them as through social, to kind of make them better, help them get through all this. Sorry, reading chat messages here. So, reactions to stress that are acute and those that develop over time can create a crisis. So, the change in behavior may be considered inappropriate or not normal by the person who calls 911. As in, they're not acting right; they're acting different today. So, a behavioral crisis or a psychiatric emergency includes patients of all ages who exhibit agitated, violent, or uncooperative behavior, or who are a danger to themselves or others. EMS is called when the behavior has become unacceptable to the patient, family, or community. They say something's they're not acting right. They're different, right? They notify law enforcement then notifies EMS and fire to respond out. Excuse me, to help take care of the patient, find out what's really going on with them. Could it be a medical emergency? Could it be hypoxia? Could it be a diabetic issue? We have to rule this stuff out. So a patient may have dementia or depression, which is a behavior that interferes with the activities of daily living. Chronic depression, a persistent feeling of sadness or despair, may also be a symptom of a mental health disorder. if you look at like nursing homes, if you look at their medical history, a lot of times you'll see chronic depression all the time. If an abnormal or disturbing pattern of behavior lasts for a month or more, it is a matter of concern. So in a from a mental health standpoint, so when a psychiatric emergency arises, the patient may show agitation or violence, or it may become a threat to self or others that are there. So the magnitude of mental health disorders, according to the National Institute of Mental Health, mental disorders are common throughout the United States, affecting tens of millions of people each year. A psychiatric disorder is an illness with psychological or behavioral symptoms that may result in impaired functioning. Anxiety disorders are among the most common that we're going to deal with in this situation. Have any of you, I haven't read all the narratives yet, during clinical rotations had to deal with psychiatric yet? During your ride time? Not yet, maybe.
I had a patient yesterday that had a history of extreme anxiety, PTSD, and some other issues.
Yeah.
So she had her baseline was an altered mental status, and then anytime, even though we were communicating with her what we were trying to do, she would like I was trying to straighten her arm out to get a more accurate blood pressure reading, and she kept pulling back from me. She was just real nervous to have us doing anything to her.
Yeah, and then sometimes you just got to do the best you can to get the assessment. I mean, unless they have a significant life-threatening injury or overdose or something like that, if it's psych, if you can get a set of vitals, great. Sometimes they won't let you do it. You got to work with it. You know, things like that. Other things that, thanks Taylor for sharing that, by the way. Other disorders, anxiety disorders also include generalized anxiety, panic disorders, social and other phobias, post-traumatic stress disorder, obsessive compulsive disorders, OCD, PTSD, ODD. There's all these different ones that are out there, and we have to learn to kind of work with it. I'm trying to work with somebody through text to get back online. Yeah, I don't see her on here now. She keeps getting booted off for some reason. All right, we'll figure it out. All right, so the U.S. mental health system provides many levels of assistance to people with psychological conditions. Professional counselors are available for mental conflicts and parenting issues. More serious issues such as clinical depression often are handled by a psychologist. And some of the most severe psychological conditions such as schizophrenia and bipolar disorder require psychiatrists to prescribe medications to assist with this, like MAOIs, SSRIs, things like that. Tricyclics, we don't see a ton of anymore. Something that you need to pay attention to for overdoses and things like that. So Joy, I see you online, showing that you're here, just so you know. I'm not sure if you can see it, but I see your text saying you can still hear it, though. All right, perfect. Most psychological disorders can be handled through outpatient visits, but some require hospitalization in specialized psychiatric units. So if you start getting into interfacility transport stuff, so if you work for us, like we work for Action Ambulance where I work now, we do not deal with a lot of transport of psychs as far as through the interfacility side of stuff. But if you work in Maine for other companies, they do a lot of discharges to psychiatric facilities where you deal with psych patients for like up to 5 miles to who knows where in the state of Maine. They send you to different facilities with these patients. But a lot of them are not bad people. You know, they need to go to a place for a couple of weeks just to be able to have one-on-one care, to be able to talk them through this stuff and get them regulated on medications, it may be meds or whatever, to find out what stabilizes their mood the best ability. Just having that ability to talk with people also helps as well, having that 24/7 access with that. Right. So psychiatric disorders may have underlying causes, social and situational stresses of divorce, death of a loved one. That could be a temporary deal. Diseases such as schizophrenia, physical illness such as a diabetic emergency, chemical problems, drug alcohol use, biological disturbances such as electrolyte imbalances that cause altered mental status. A lot of different things are here that can cause that psychiatric disorder that can be stabilized with medications and whatnot. So schizophrenia, I used to do this with my students that were in person. It's very hard to do this online. I've never actually tried it before. But if you go to YouTube and type in like the mind of a schizophrenic, right, or something like that, similar to those, what you do is what it does is it plays you a recording of what it's like to be schizophrenic. And I did this in paramedic school years ago. One of the activities we did in class was we had to listen to this with our eyes closed. In the classroom, we played it out loud. The mind of a schizophrenic. And then try to think of a grocery list that we need for groceries up to 10 items. And try to think of that in your head while listening to the voices of someone who's schizophrenic in your head itself. So it was quite interesting. I couldn't get 10 items. I tried, but the voices that were in my head during that wasn't allowing me to be able to make that list I was looking for. But now keep in mind that was for 5 minutes of listening to this. Schizophrenics deal with this 24 hours a day, 7 days a week, of them thinking that they're useless, they're worthless, they can't do anything good. The people are watching you too, whatever. Imagine having that going on in your head over and over and over and over again. It's tough. It really is. So, all right. So as an EMT, an EMT is not responsible for diagnosing an underlying cause of behavioral crisis or psychiatric emergency. You should understand the two basic categories of diagnosis a physician will use: either organic, physical, or functional, psychological. So physical or psychological. Organic disorders, organic brain syndrome is a temporary or permanent dysfunction of the brain caused by a disturbance in the physical or psychologic functioning of the brain tissue. Causes would be a sudden illness, traumatic brain injury, seizure disorders, drug and alcohol abuse, overdose, or withdrawal. Diseases of the brain, such as Alzheimer's disease or meningitis. Keep in mind that altered mental status can also arise from hypoglycemia, hypoxia, impaired cerebral blood flow, like a head bleed or a stroke, hyperthermia or hypothermia. So in the absence of psychological cause, altered mental status may also be an indicator of a psychiatric disorder, such as bipolar disorder. If they are altered, you need to check a blood sugar. You need to get a set of vitals. You have to make sure that it is not something that is correctable, like hypoxia, hypoglycemia, something that we can fix to bring their mental status back to normal again, right? So find those correctable causes, potential causes, and treat them. So functional disorders of a psychological disorder that impairs bodily function when the body seems to be structurally normal. Examples would be like schizophrenia, anxiety conditions, and depression. The chemical or physical basis of these disorders does not alter the appearance of the patient. They could look like a normal person walking down the road, but the voices in their head can be telling them to jump out in traffic. Okay, so you just got to keep that kind of stuff in mind. When dealing with them, get down to the same level and have a conversation. Approach the patient. Do your assessment, patient communication, obtain a history, providing care, or all used in behavioral crisis. Other management techniques are also involved with this. So a safe approach would be to assess the scene, ensure that you have the means of communication, know where all the exits are, so make sure you can get out. Don't put yourself between a patient between you and the door. Don personal protective equipment. Have a definite plan of action. Urgently de-escalate the patient's level of agitation and calmly identify yourself of who you are. So my name is Kevin. I'm a paramedic here at the ambulance today. I'm here to help you. What can we do for you? You know, let them know that you are there to help, not become more of a nuisance. Follow the guidelines on the listed table 22.1 to ensure that your safety and scene and behavioral. So you'll be able to see that in your books, in your ebooks. But be direct, be prepared to spend extra time. Psych patients may take a while to get them moving. Stay with the patient. If they have to go to the bathroom, follow them, because they could be going to the bathroom to do something of harm to themselves. Do not get too close to a potentially violent patient, as they could hurt you. Express interest in the patient's story. Right? Don't just blow it off and roll your eyes and look the other way. Actually get involved in their conversation. Avoid fighting. Do not be that a-hole telling the patient what to do, how to do it, and be that jerk. Work with them. Be honest, reassuring, and do not judge them. Right? They're already going through a hard enough time as it is. You just got to get them to calm down. Scene safety. The first thing to consider is make sure the scene is safe and the patient responds to the environment. Is the situation potentially dangerous for you or your partner? Do you need immediate law enforcement backup? Should you stage? Right? If it's a violent patient, yeah, we should be waiting until PD gets there to clear the scene. We don't know what's going to happen, what kind of weapons they have, but PD clear. They're the ones that have the power of arrest. They also carry guns, tasers, and other fun stuff. So, does the patient's behavior seem typical or normal for the circumstance it's there? Are there any legal issues involved? Crime scene, consent, refusal, things to think about. So take appropriate standard precautions and request any additional resources you may need. Law enforcement, additional personnel early. Get them coming if you need help. If they're a combative patient, you think you have to do a takedown of somebody, you're going to need more than just you and your partner. If you think you need to have chemical restraint, then you need to call for a paramedic to come in and use chemical restraint to assist. Mechanism of injury or nature of illness. Determine the mechanism of injury or the nature of illness, what's going on. If it's a mechanism of injury and they fell and hit their head and now they're altered, it's a head. It could be potential head injury, TBI potentially, right? Versus the nature of illness. Note any medications or substances that may contribute to the complaint or may be for treatment of a relevant medical condition that's there. Look at their medication list and see if there are medications to assist with bipolar, schizophrenia, things like that. Are they taking meds for depression? Right? You want to look at that kind of stuff. We're going to do our primary assessment, form a general impression, sick or not sick. Begin your assessment from the doorway or from a distance. How does the patient appear? Do they appear agitated? Are they pacing? Are they walking? Are they pinch class? Are there fist clenched. Begin with an introduction of who you are, even from a distance. Hey, my name is Kevin. I'm here to help you. Here are the ambulance. Perform a rapid physical exam. Look for trauma, especially head trauma. Observe the patient closely. Use the AVPU scale to check for alertness. Establish a rapport with the patient. Talk with them. Most medical or trauma situations will include a behavioral component. So treat the whole patient, the behavioral component, as well as the medical or traumatic issue. Again, look at the entire patient. Never raise your voice. You don't want to yell at anybody else. Just reading some of the comments that were put up here. Never raise your voice and never turn your back to them when you're communicating with them. Show that you're invested, that you want to talk with these patients, right? Other techniques you can utilize too as well when patients are on stretchers, especially with dementia patients, is turn your buckles upside down, because dementia patients always want to push down, not push up underneath, to help to keep the buckles in place on your stretcher. If you have a psych patient that's willing to run or potentially could be a jumper to get out, they always like to have a plan of attack. So wheel them into the hospitals backwards so they can't see where they're going. All they can do is see where they came from. Kind of little techniques that we picked up along the way to kind of help with that. Airway breathing. Any signs of distress, treat it. Evaluate the patient. Provide appropriate interventions. It's the same as every other patient. Circulation, rate, rhythm, and quality. Because if they could have taken some kind of medication as an overdose, and you want to make sure that their heart rate, rhythm, and quality are normal. Evaluate the presence of shock and bleeding, and assess the patient's perfusion by evaluating skin color and temperature and capillary refill. Make a transport decision. If the patient's unstable from a medical problem or trauma, prepare to spend more time. Unless the patient is unstable, prepare to spend more time. It may take time to gain the patient's trust, but if it's a medical condition or trauma condition that's critical, then we have to get going. History taking, investigate the chief complaint, and then obtain a sample history, allergies, medications, medical history, last oral intake, events leading to illness or injury. Consider 3 major areas as possible contributors. 1. Is the patient's central nervous system functioning properly? 2. Are hallucinogens or other drugs or alcohol a factor? And 3. Are significant life changes, symptoms, or illness caused by a mental rather than physical factors involved? So getting your sample history, you may want to enlist more information not available to the hospital staff. So ask about previous episodes, treatments, hospitalizations, any medications related to behavioral problems. In geriatric patients, consider Alzheimer's disease and dementia as possible causes of the abnormal behavior. Determine the patient's baseline mental status to guide treatment and transport decision. This information will be extremely helpful to hospital personnel. Obtain information from relatives, friends, observers, caregivers. Remember that your assessment of the situation has 2 primary goals: recognizing major life threats and reducing the stress of the situation as much as possible. Use reflective listening to gain insight into the patient's thinking. Repeat in question form what the patient has said. This encourages the patient to expand on the thoughts that they have. So let them have them help you. So this table on the slide lists the questions to ask in evaluating a mental health disorder. Does the patient appropriately answer your questions? Does the patient's behavior seem appropriate? Does the patient seem to understand you? Is the patient withdrawn or detached, hostile or friendly, happy or depressed? Are the patient's vocabulary and expressions what you expect under the circumstance? Does the patient seem aggressive or dangerous to you or others? Is the patient's memory intact? Check orientation to time, place, person, and event, and what day, month, and year it is. Who am I? Does the patient express disordered thoughts, delusions, or hallucinations? So, in an unconscious patient, begin with a physical exam to look for a reason for the unresponsiveness. Rule out trauma, especially to the head. Conduct a detailed physical exam and obtain a complete set of vitals. Obtain vital signs if it is possible to do so without worsening the patient's emotional condition. You want to make every effort to assess blood pressure, pulse, respirations, skin, and pupils, and consider whether prior events such as physical agitation, use of stimulants, alcohol withdrawal, or taser exposure may be contributed to the patient's condition. When examining a patient, you also remember to, with a behavioral emergency, is check for track marks indicating drug abuse and signs of self-mutilations. Look at the arms, the legs. If people want to hide shooting up, check between their toes as well. That's a very, very common place, especially if they actually go to work where their arms are going to be exposed a lot in the job that they do. So a lot of times they'll find other places to shoot up so that there it can be hidden. A conscious patient may not respond to your questions as well, so keep that in mind. Let's see. So you can tell a lot about a patient's emotional state, looking at facial expressions, pulse rate, respirations, tears, sweating, blushing may also be significant indicators of a state of mind. Look at the patient's eyes. Is it a blank gaze, I should say, or rapidly moving eyes may lead you to the patient experiencing central nervous system dysfunction. Patients that are on meth tend to move their eyes around and just they can't focus. They'll find one thing and stick with it, and then they'll jump to the next, and the next, and the next, and the next. They really can't sit down and just focus and stuff. I see that a lot with patients that are methed out as well. Transport decisions. So when available, have law enforcement personnel or firefighters accompany with you in the back during the transport if you can. If the patient is handcuffed to your stretcher, law enforcement has to be in the back with you. They cannot follow in a cruiser behind. They have to be in the back. So you're better off using soft restraints than handcuffing somebody. There may be a specific facility to which the patients in psychiatric emergencies are transported to around where we are, closest hospital. Transport by ground rather than air. The last thing you want is a psych patient going crazy up in a helicopter. Try to make the patient comfortable. Placing a stretcher in Fowler or high Fowler's position helps prevent aspiration and reduces physical exertion as well. When you're doing a reassess, remember, never let your guard down. Many patients experiencing a behavioral crisis will act spontaneously. To be prepared to intervene quickly if restraints are necessary. Reassess and document the patient's respiration as well as pulse, motor, and sensory function in all restrained extremities every 5 minutes. Interventions. Your heart may go out of the emotionally distressed patient, go out to them. So there's often little you can do during a short time you'll be treating them. So your job is twofold. One, diffuse and control the situation, and two, safely transport the patient to the hospital. Intervene only as much as it takes to accomplish the tasks. Be aware of standard precautions, and also if you encounter a situation where you think a pharmacologic restraint may be necessary, request ALS for as early as possible. We have the abilities of using medications like Versed, Valium, Haldol, ketamine, things like that to chemically restrain somebody if needed. So if you think the patient's going to be out of control and they might need a chemical restraint, then notify a paramedic to respond out to your location to do it. But start them early if you think it's going to be needed. All right. So communication and documentation. So give the receiving hospital advance warning of a psychiatric emergency. Document thoroughly. As well, many hospitals require extra preparation to ensure appropriate staff and rooms are available. So if you have a psych patient coming in, you want to make sure you get that information to them sooner than later, right? To help with that. Or then they can start prepping rooms and everything else. Because a lot of times they have locker rooms that have to be done. And maybe they have to move people around. I know that some smaller hospitals only have like 1 or 2 psych rooms that can lock up. The rest of the time they have to have security doing door watch and they have to clean out rooms. So it's good to give them a heads up so they can start planning for that. Give them a heads up when you're on scene as well. All right. So it is noontime now. We're just getting into the next session about psychosis. Do you want to finish up this lecture and then take lunch, or do you want to take lunch now and come back in an hour? I told you guys noontime. We probably have about another hour, so less than that. I'm seeing finished lecture. Let's do this from 2. I need more than just 2, you guys. Anybody else want to jump in? Let me know. Want to keep going with this instead and take the hour lunch after we're done? So I think the majority has said finish it. People are already eating. All right, so this just is being recorded anyways. You can always go back. All right, so we'll continue on. We'll finish up this chapter. Then we'll take an hour lunch, come back and do the last 2. So let's keep going. So acute psychosis. Psychosis is a state of delusion in which the person is out of touch with reality. Some causes would be mind-altering substances, intense stress, delusional disorders, and schizophrenia. Some episodes last for brief periods, others last a lifetime. All right. So schizophrenia is a complex disorder that is not easily defined or easily treated. The typical onset occurs during early adulthood, with symptoms becoming more prominent over time. Influences to this thought to contribute to the disorder is brain damage, genetics, and psychological and social influences. There we go. So symptoms would be delusions, hallucinations, a lack of interest in pleasure, and erratic speech for schizophrenia. Guidelines for dealing with a psychotic event. Once you determine if the situation is dangerous, clearly identify yourself when you are there. Be calm, direct, and straightforward, and maintain an emotional distance. Right? Please do not get into their bubble. Do not argue with them. Let them talk. Don't get into a disagreement and a fight. All right? Explain what you would like to do. Do you mind if I take a blood pressure? Do you mind if I check your pulse? I'd like to see you take a ride to the hospital and have someone talk to you. Right? They have facility or they have the ability to do teleconference with people that can help to help make determinations on where people go they can get admitted to psychiatric facilities. Northern Human Services does a lot with that. They do teleconference calls with it. All right. So excited delirium. Delirium is a condition of impairment in cognitive function that can present with disorientation, hallucinations, or delusions. Agitation is a behavior characterized by restless and irritable physical activity. Although patients experience delirium generally are not dangerous, if they exhibit agitated behavior, they may strike out irrationally. This would be more of your agitated delirium. In such cases, your personnel and your personal safety must be considered. Symptoms would be hyperactive, irrational behavior, vivid hallucinations, hypertension, tachycardia, diaphoresis, and dilated pupils. So be calm, supportive, and empathetic. Be an active listener, nodding, indicating understanding, limiting your interruptions in the patient's comments. Let them finish talking, right? If they're talking to you and they're alert and oriented to the best ability, we know they have a patent airway, they're breathing, and if they're pink, warm, and dry, they have good circulation. So let them keep going. Approach the patient slowly and purposefully and respect the patient's personal space. Like I said before, stay out of their bubble. All right, let them have their space. Keep your 6 feet. Limit physical contact as much as possible. All right, if they let you get a blood pressure, let them. They tell you to stop, then stop. And never leave your patient unattended. Use careful interviewing to assess the patient's cognitive function. Try to indirectly determine the patient's orientation, memory, concentration, and judgment. Pay particular attention to the patient's ability to communicate early and make notes of the patient's apparent mood. Pay attention to the patient's appearance, dress, and personal hygiene as well. So kind of look at everything as one whole package. How well are they taking care of each other? If the patient appears to be experiencing an overdose, take all the medication bottles or illegal substances with you to the medical facility. The patient should be transported to a hospital with psychiatric facilities. Again, every hospital that we transport to has an ability to start a psychiatric process. So, with that being said, get them to any local hospital. Right? We do not do transports directly to psychiatric facilities. Right? They have to be admitted and accepted before that happens. And whenever possible, please refrain from using lights and sirens as well. If the patient's agitation continues, request ALS assistance so chemical restraint can be considered. Uncontrolled or poorly controlled patient agitation can lead to sudden death, from sudden cardiopulmonary arrest to physical agitation through the result of metabolic acidosis. Physical control measures include tasers, positional asphyxia, which occurs when a patient's physical condition restricts the chest wall movement or causes airway obstruction. Patients with excited delirium may require ALS intervention, where they have to be paralyzed and sedated, or should I say sedated and paralyzed and intubated as a punitive effect to protect the patient and the crew. Excuse me. So restraint. Every pre-hospital care provider, transport provider should create and follow a pre-hospital patient restraint protocol. So again, they vary. So read your state protocols, Maine, New Hampshire, and look at the restraint setup. When you do restrain patients, you want to make sure that you restrain, and I'll show you guys in the next slide here, how to hold the patient down appropriately to prevent them from hurting themselves, but also how to put on the restraints as well. Personnel must be properly trained, so you should get restraint training within your service you get hired with. If you restrain a person without authority in a non-emergency situation, you expose yourself to a possible lawsuit. Legal actions can involve charges of assault, battery, false imprisonment, and violation of his civil rights. In a non-emergency situation, you can't just restrain anybody because you feel like it. Even on interfacility transport, you have to have a physician's order to restrain. In 911 settings, if the patient is agitated and you feel that someone is going to get hurt, you can put them in restraints with that. Just notify medical control so they know that they're coming in with a person who's been restrained. They can have security present or law enforcement. You may use restraints only to protect yourself or others from bodily harm and to prevent the patient from injuring him or herself. If you look at the picture that is here, right, one arm is restrained down low, the other arm is restrained up high. Never put a patient face down, right? That can cause asphyxia. And never have them laying down flat. You can sit them up a little ways so they can still breathe. You may only use reasonable force as necessary to control a patient. It does not mean that you can beat the hell out of them. Enough force to protect and control the patient and protect yourselves. Again, follow local protocols and involve law enforcement if the patient is in a severe behavioral crisis or psychiatric emergency. Law enforcement personnel will also provide physical backup in managing the patient and serve as a necessary witness as a legal authority as well. So the patient who is restrained by law enforcement personnel is in their custody. Before considering physical restraint, use verbal de-escalation techniques. Try to talk them down. Asking a family member to assist you. That usually does work. Be honest and straightforward and talk in a calm, friendly tone. If this is not working and we need to actually restrain them, once the decision is made to restrain a patient, you should carry it out quickly. Do not fool around. Take your time. If you need to take somebody down to restrain them, then do it right away. Make sure you have adequate help to restrain the patient safely. Then, ideally, 5 people should be present to carry out a restraint. 1 responsible for each extremity and 1 responsible for the head. There should be a team leader who directs the process and a plan of action before you begin. Use the minimum force necessary to control a patient. Do not go in there to hurt somebody. It's to get them restrained so that it protects you and themselves from harm. The level of force will vary depending on these factors. The degree of force that is necessary to keep the patient from injuring themselves or others, a patient's sex, size, strength, and mental status, including possibility of drug-induced states, and the type of abnormal behavior the patient is exhibiting. You or your partner should talk to the patient throughout the entire process. Treat the patient with dignity and respect at all times. If possible, a provider of the same gender should attend to the patient out back during the transport. Where appropriate, barrier protection during patient restraint activities because they will spit, bite, or whatever else potentially could come out of them. They could pee on you, it doesn't really matter. They'll find a way to distract you or hurt you in some way, shape, or form. We cannot start putting masks over we can put masks over their face. We got to be very careful on how we do that. Please do not put pillows over their head or their face. Do not put them in a backboard sandwich. Those are not allowed. Avoid direct eye contact and respect personal space. Never leave a restrained person unattended. All right, especially if they have positional asphyxia and they end up dying on your stretcher. Do not place anything over their head, face, or neck. If the patient is spitting, a surgical mask may be placed loosely over the patient's mouth. and the patient attempts to bite, a hard cervical collar may be placed on the patient's neck to keep their jaw from moving. Then we're going to monitor the patient for vomiting, airway obstruction, respiratory status, circulatory status, blood pressures, and changes in level of consciousness. We're going to reassess the airway and breathing continuously and make frequent checks of circulation. Restraints applied in the field should not be removed until the patient is evaluated at the receiving facility. And we will go over the skill drills when we see you in person on how to properly restrain somebody. All right, so the potentially violent patient. Violent patients make up only a small percentage of the patients undergoing a behavioral or psychiatric crisis. However, the potential for violence is always a critical consideration for the EMT. So assess the level of danger based on the following risk factors. History. So has the patient previously exhibited hostile, overly aggressive, or violent behavior? And posture. How is the patient sitting or standing? Is the patient tense, rigid, sitting on the edge of his seat or her seat? Excuse me. The patient, looking at the scene itself, is the patient holding or near potentially lethal objects, knives, swords, whatever? Just, again, keep an eye out. What kind of speech is the patient using? Is it garbled, not making any sense? Is it verbal, vocal, profanity, threats? Loud, obscene, erratic, or bizarre speech patterns usually indicate emotional distress. So got to keep this stuff in mind. Physical activity, the motor activity of a person undergoing a psychiatric emergency may be the most telling factor of all. So a patient requiring careful watch is one who has a tense muscles, clenched fists, or glaring eyes. Are they pacing? They can't sit still, and they're fiercely protecting their personal space. Right? These are your agitated patients that can potentially become physically violent. Other factors is poor impulse control, a history of taurgency, fighting, uncontrollable temper, history of substance abuse, depression, accounts for 20% of violent attacks, functional disorder. So the patient tells you the voices are telling him or her to kill, believe it. They may follow those as well. So again, if you think that they're saying, my mind is telling me to kill you, you might want to back off because they're probably going to try and make that attempt. All right, so suicide. Depression is the single most significant factor that contributes to suicide. It is a common misconception that people who threaten suicide never commit it. Suicide is a cry for help. Threatening suicide is an indication that someone is in a crisis that he or she can no longer handle alone. These need and require immediate intervention. So be alert of the warning signs. Air of tearfulness, sadness, deep despair or hopelessness, avoiding eye contact, speaking slowly, and projecting a sense of vacancy, unable to talk about the future, suggestions of suicide, having a plan related to the death. Do they have a plan to hurt themselves? And if so, what is the plan? Are they homicidal? Do they have plans of hurting somebody else? Or we need to get this information from them. These are some of the risk factors. Again, way too small on my screen to even see. All right, moving forward. So consider these other additional risks. Are there any unsafe objects nearby? If they are, remove them. Is the environment unsafe? If the environment's unsafe, get them to a safe environment. Is there evidence of self-destructive behavior? Is there an imminent threat to the patient or others? Are there cultural, religious, or social beliefs promoting suicide? Has there been any kind of trauma? It doesn't have to be trauma as far as physical, but it could be emotional trauma as well. Try to get this information out. Is there any underlying medical problems? Try to get a history from family. Have you had repeat calls to this location? If so, what were they? Were they domestic calls? Are there cultural, religious, social beliefs promoting the suicide? Has there been any kind of trauma? Remember that a suicidal patient may also be homicidal, which we just talked about. If you believe they are in danger, obtain police intervention. The most important service you can provide for a suicidal patient is compassionate transport to a medical facility where the patient can receive proper treatment. We are not psychologists. We are not psychiatrists. We do not do this type of work. We need to get them to who does. All right, post-traumatic stress disorder and returning combat veterans. PTSD can occur after exposure to or injury from a traumatic event, like serious accidents, child abuse, sexual and physical assaults, or some other ones. Natural disasters, war, loss of a loved one, stressful life changes. PTSD is not necessarily a result of one isolated or recent event. An estimated 7 to 8% of the general population will experience signs of PTSD at some point in their lives. Military personnel who have experienced combat have a high incidence of PTSDs. Remember, reminders of their experiences in the military from news coverage or gatherings of veterans could also be triggers. Find out what those triggers are. Try to see if you can talk with them and try to calm them down, de-escalate that situation. I've seen a lot of interesting stuff going in the nursing homes, especially ones that have dementia or Alzheimer's. They start getting flashbacks of previous wars that they were in. So those are some things to think about. Some other symptoms of PTSD include feelings of helplessness, anxiety, fear, and anger. So they may avoid reminders of the trauma, loud noises or smells, or interactions with people that remind them of these. They suffer constant nervous system arousal that is not early suppressed. So heart rate increases, pupils begin to dilate, and systolic blood pressure will go up. So senses of sharpened and mental acuity is definitely heightened in this. So the victim may be hypervigilant or display an exaggerated startle response to perceived danger. This can relive the traumatic event through intrusive thoughts, nightmares, or even flashbacks. Disassociative PTSD occurs when a person attempts to find an escape from constant internal distress or a particularly disturbing event. Other psychological conditions, such as personality disorders and increased functional impairment, can develop in individuals with this type of PTSD. So combat veterans are prone to early heart disease, high incidence of type 2 diabetes, loss of brain gray matter, and higher incidence of traumatic brain injury. Another consideration with them is higher incidence of TBI sustained from trauma secondary to an explosion of a IED. So symptoms may go undiagnosed for several reasons. Similar to PTSD symptoms, the patient may downplay the symptoms as well. So healthcare providers should eliminate excess noise, refrain from touching or doing anything to the veteran without an explanation, and keep their diesel equipment far away as well. So when caring for a combat vet, the returning combat veteran is a patient who require unique level of understanding, compassion, and specialized attention. So be careful how you phrase your questions. Use a calm, firm voice, but be in charge. Respect a veteran's personal space. Limit the number of people involved or to a private space, and ask about suicidal intentions or any kind of suicidal ideations. All right. You also want to ensure that there is nothing the patient can access or be used as a weapon as well. But physical restraints may simply escalate the problem. You can get them in the back of the ambulance to go seek some help without going into physical restraints, then do so. Right? We don't want to escalate the problem any more than what it already is. If it is necessary to calm the patient, especially if there are safety concerns, chemical restraints administered by ALS should be considered for these patients. So medical legal. The medical legal aspects of EMS are more complicated with patients undergoing behavioral crises or psychiatric emergencies. Legal problems are reduced when the patient consents to care. Gathering the patient's confidence is critical with this. Right? So you must decide whether the patient needs immediate emergency care or not. So a patient mentally unstable condition may resist your attempt to provide care. Do not leave the patient alone, and doing so may result in harm to the patient and expose you to a civil action for abandonment or negligence. So if you can't get the patient to go to the hospital and they're making suicidal threats, get law enforcement involved. Right? Remember, they have the ability to PC people. Right? We do not. Consent. Implied consent is assumed with a patient who is not mentally competent to grant consent. Consent matters are not always clear cut in psychological emergencies or psychiatric emergencies. It can be difficult, right? Because we're not exactly sure what's really going on. Are they able to make decisions on their own? Or are they not to? So the best word of advice is to contact medical control and get guidance from the physician at the hospital on what to do. So the EMT has limited legal authority to require or force a patient to undergo emergency care when a non-life-threatening emergency exists. So you should be familiar with your local and state laws regarding these situations as well. Competent adults have the right to refuse care. If they are refusing care and you feel they should go as a patient advocate, then contact medical control and see if the physician can talk with the patient prior to transport. In psychiatric cases, a court of law probably consider your actions in providing life-saving care to be appropriate, but a patient who is in any way impaired may not be considered competent to refuse treatment and transportation. Always maintain a high index of suspicion regarding the patient's condition and assume the worst and hope for the best. Err on the side of treatment and transport. Carefully document the patient's statements and behavior to support your actions. Be careful with patient refusals on these. If you have a patient refuse and you sign them off and they go and they kill themselves 20 minutes later, it doesn't look good on our part. We need to make sure we're documenting the best we can on why and what we tried to do to get the patient to go to the hospital. We look at things called high-risk refusals, and psychiatric suicidal refusals are high risk. Contact a physician. Pass the buck to a doctor. Right? Make sure you get the doctor's name too as well. Document that in your narrative. All right, so let's go over some review questions and then we'll take an hour. A behavioral crisis is most accurately defined as there is a C and a D, but I can't go to the next slide yet. So it's A and B. That's C and D. All right. So the answer is B. I hit the wrong button. Sorry, Nick. Going back, that was A and B. All right. Number 2, depression and schizophrenia are examples of right. I only have 2 people that have answered it so far. Number 2, there we go. That was starting to come in. All right, so the correct answer is A, the functional disorder. Number 3, when assessing a patient with a behavioral crisis, your primary concern must be your primary concern.
D.
D, awesome. All right. Will they cause harm to self and others? General guidelines to follow when caring for a patient with behavioral crisis include all the following except all of the following except all right. All right, answer is B. You may need, remember, you may need to spend some extra time. So rapid transport is not required unless they're critical. That would change it. Reflective listening, an assessment technique used when caring for patients with an emotional crisis, involves all right. Let's see, D's popping up. Perfect. All right, number 6. Which of the following patients is at highest risk for suicide? All right, C it is. Number 7, when caring for a patient with an emotional crisis who is calm and is not in need of immediate emergency care, your best course of action is to all right, good job. C. When physically restraining a violent patient, the EMT should all right, A. Continuously talk to the patient as he or she is being restrained. Let them know what is going on. Talk with the patient. Upon arrival at the residence of a young male with an apparent emotional crisis, a police officer tells you that the man is acting bizarre. You find him sitting on his couch. He is conscious but confused and takes medications, but cannot remember why. His skin is pale and diaphoretic, and he has a noticeable tremor to his hands. You should first rule out he's pale, diaphoretic, and he's shaking. You guys should be checking a blood sugar. Hypoglycemic. Check a blood sugar. Number 10, which of the following signs is least indicative of a patient's potential for violence? All right, good job, B. So before we break for lunch, we'll come back at 1:40. We just stopped the recording really quick.
This conference will now be recorded.
All right, so chapter 24, trauma overview. All right, so standard competencies applying fundamental knowledge to provide basic emergency care and transportation for the trauma patient. And switch, there we go. So we're going to cover patho assessment and management of trauma scoring, rapid transport and destination issues, transport time. I also have a video that I want to show you guys as well. I'm hoping that it will play. Actually, maybe I've already shown it to you. In the chat box or reply, did I show you guys the DART video yet on what they offer for trauma services on our last practical day?
I don't think so.
No.
All right, so I will show you guys that as well at the end of this trauma here. I'll show you guys the DART video. Hopefully it'll play well over the system. It should. Multi-system trauma, recognition and management of multi-system issues. Keep in mind that multi-system trauma, remember, is not like an arm fracture and a femur fracture, because those are all skeletal. It's the actual system. So like endocrine system, you know, musculoskeletal, respiratory, cardiac, but multiple systems involved, the multi-system. Blast injuries as well. All right, so people younger than 44 years old, traumatic injuries are the leading cause of death in the U.S. So proper pre-hospital evaluation and care can reduce suffering, long-term disability, and death from trauma. We have to make sure we're doing a detailed assessment and rapid assessment on these trauma patients to find these significant injuries, right? We need to expose our patients. It drives me batty to see patients come into the ER when I worked at the emergency department that are involved in traumatic injuries that didn't have their clothes cut off of them. And when you cut off their clothes, you find deep lacerations and fractures and things like that that they have missed because they didn't expose their patients, right? So expose. Trauma emergencies occur as a result of physical force applied to the body of some sort, whether it be penetration, blunt force trauma, things like that. Medical emergencies occur from an illness or condition not caused by an outside force. But here's a question for you guys. Can a medical emergency cause a traumatic injury?
Yes.
Absolutely. Absolutely you can. All right. So when you're at a motor vehicle accident or a fall, look around and see if there's other clues that potentially could have caused this to happen. All right, stand by, guys, for a minute.
Saw that last night, and we did cut our clothes off.
Perfect. Trauma naked. That's the way to be. All right, I had to reply back. All right, so continuing on. Not that fast though. So traumatic injuries may be caused by underlying medical conditions or medical illness, may result from a recent remote traumatic injury. We talked about that already. Evaluation of the mechanism of injury for the trauma patient will provide you with an index of suspicion for different types of serious and or life-threatening underlying injuries. All right, so looking at motor vehicle accidents and looking at the mechanism itself of what should happen if a patient was involved in this kind of injury or kind of crash, you know, under the dashboard, through the windshield, motorcycle accidents, ATVs, things like that. So index of suspicion is your awareness and concern for potentially serious underlying and unseen injuries. So we look at energy in trauma, okay? This is how a lot of things happen. We have to have the energy that's there. Traumatic injury occurs when a body's tissues are exposed to energy levels beyond their tolerance, all right? So mechanism of injury is the way traumatic injuries occur, which then describes the forces or energy transmission acting on the body that can cause injury. So let's go over the three concepts. Right? There are three concepts of energy that typically are associated with injury: potential energy, kinetic energy, and energy of work. All right. So energy can neither be neither created nor destroyed, but can only be converted or transformed. We'll talk about that in a little bit in blast injuries and whatnot. So work is defined as force acting over a distance. So forces that bend, pull, or compress tissue beyond their inherent limits result in work that causes injury. Right? So you can take so much before something gives and breaks. So let's talk about the kinetic energy with it. Not that much. So kinetic energy is the energy of a moving object that reflects the relationship between the mass, which is the weight of the object, and the velocity, which is the speed at which it is traveling. So KE, kinetic energy, equals half the mass times velocity squared. So according to the equation for kinetic energy, the energy that is available to cause an injury doubles when an object's weight doubles but quadruples when its speed doubles. Potential energy also is the product of mass, force of gravity, and height, most associated with the energy of falling objects. All right. So with that, mechanism of injury profiles, different types of MOIs will produce many types of injuries. We'll have non-significant MOIs, injury to an isolated body part, or a fall without a loss of consciousness. All right. So you fall 5 feet, you injure your ankle. Right? That's a non-significant MOI. Right? Fall 5 feet. But what would happen if you fell 30 feet? Would that now be significant? Yeah, absolutely it would be. So our significant injuries or injury to more than one body systems, or a multi-system trauma, fall from height. So if you fall from standing height, that's not necessarily a significant injury. However, you also got to play other things in the factor, right? If someone who's elderly, who has osteoporosis, who falls and fractures their pelvis from his fall from standing height, could that be a significant injury? Yeah, it could. You know, so you got to look at everything as a one big profile, everything that's there. So the patient, the condition, the age, the fall, everything all together. Motor vehicle and motorcycle crashes, absolutely. High mechanism. Car versus pedestrian or bicycle, gunshot wounds, stabbings. We gotta look at all these things. These are all significant injuries that can cause a lot of damage, right? A stabbing, we have no idea where that's going to go. How deep the blade is, the type of blade that it is, how long the blade is, how far it went in for a stabbing, how many times were they stabbed, they hit any organs within the system. Gunshot, if it's not a through and through, it can bounce off other things and stay lodged somewhere in the system where we can't see. So obviously, significant injuries. All right. And here's another thing too with car versus pedestrian. All right. The mechanism, the profile of injury will be different from a child versus an adult. So if we, as an adult, are about ready to be hit by a car, what do we do? If you can't get out of the way,
prepare for it.
Right, you tense up, and how do we prepare for it though? Do we turn and jump towards the car, or do we turn away from the car and kind of prepare for the impact? Which one do you guys think it is? Do you think we turn away? Turn away? Yeah, see Nick putting on there. Yep, Tondra, turn away. Yep.
I think it would be based on the amount of time and distance between you and the car.
Right, but if you have a chance, if you can't jump out of the way, you kind of turn and duck, right? To kind of prepare for an impact. A child is not going to do that. They're going to turn towards the car, being like, what is this? What's going on here? They haven't built that reaction to turn away yet, right? So that's what you're going to see with that, is they're going to turn towards the vehicle versus turning away. So the impact is going to be more frontal versus the backside of them. You're going to see more of a frontal impact, so face, chest, things like that, versus an adult who normally would turn away. You'd have more like pelvis, hip, back injuries, and things like that. So again, looking at the mechanism of injury and then the age profile of what they potentially, based on statistical data, would do. You got to kind of keep that kind of stuff in mind. So blunt and penetrating trauma. So traumatic injuries can be divided into two separate categories, either blunt or penetrating. Blunt trauma is a result of a force of the body that causes injury without penetrating the soft tissue or internal organs or cavities. So me taking a baseball bat to somebody would be more of a blunt force trauma. Penetrating trauma causes injury by objects that primarily pierce and penetrate the surface of the body and cause damage to soft tissues, internal organs, or other body cavities. Either type may occur from a variety of mechanisms of injuries. It's important to consider unseen as well as visible, obvious injuries with either type of trauma. Okay, so again, if I smash you over the head with a baseball bat, what do you expect to see? But if I take a gun and I shoot you with it, we're stars, exactly. Or depressed skull fracture. But what we don't see is the bleeding underneath, unless we see that hematoma. So now do we have a subarachnoid bleed, subdural bleed? What do we have else going on that we cannot see underneath there, right? So those things, because they get hit in the head, that's perfectly fine. Now, one of the biggest things that we miss with blunt force trauma, all right, let's just say you have someone on blood thinners, 70-year-old male on blood thinners in a nursing home, trips and falls and hits his head on the ground. Nursing staff goes in and goes, yeah, he's fine. We'll call the ambulance just to make sure. Okay, so the ambulance shows up. We transport him to the hospital. They get a head CT done. Everything comes back clean. A week later, a patient's unresponsive. You should be asking, has he had any recent falls? Is he on blood thinners? Because he may have developed a very, very, very slow head bleed that got worse and worse over the last week. Right? So you got to keep that kind of stuff in consideration. Looking at their medical history, looking at medications, get that sample history down pat, understand it, know it. You know what I mean? So having all that information will help determine, is this an actual hemorrhagic stroke? Is it a bleed? What could it potentially be? So history taking is very important. So blunt trauma results from an object making contact with the body. Motor vehicle crashes, falls are the most common MOIs. So be alert to skin discoloration, pain, because these may be only signs of blunt trauma. And maintain a high index of suspicion for any kind of hidden injury. So things to look at with motor vehicle accidents, they're classified as these different categories. A frontal impact, which is head-on, rear end impact, lateral, T-bone, rollovers, and rotational injuries. So these principal differences is the direction of the force of the impact. All right. So a crash typically consists of 3 collisions, okay, in a motor vehicle accident. A car against another car, tree, or an object. So damage to the car does not directly affect the patient, but does provide information about the severity of the collision itself. So by assessing the vehicle that has crashed, you can often determine the mechanism of injury. Okay, so if I have now I understand cars are made to be a lot safer nowadays. I got it. Right, we show up the car accident and go, oh my God, is this a fatal? And the guy's outside on his cell phone calling for a ride home. Right, you take a car from the 1960s or 70s and do that, they're probably going to be dead. Right, but cars nowadays are meant to crumple. They're meant to absorb that impact for a collision. However, if we have a frontal impact, what do we expect to see happen to that patient? And we're going to go with them not being seatbelted. What do we expect to see? Okay, Nick said
Head injuries.
Head injuries, right? So how are we going to determine what indicators are we going to look for in the vehicle to as indicators that there's a head injury, a chest injury, pelvic injuries, things like that?
Are we talking about like spidering of the windshield?
Absolutely. Spidering of the windshield would indicate head trauma, right? What about the steering wheel? Hair in the windshield, right? Tondra just mentioned that. Right? Tondra mentioned deformed steering wheel. If I go to a vehicle and I see the steering wheel deformed and bent, what am I considering? Chest trauma, right? Everybody should be saying chest trauma. Okay. Now, Nicole,
Or even extremities,
yeah,
like
so,
arm extremities if they're holding onto it.
yeah, we'll get to that too. Airbag deployment coming out at 300 plus miles an hour, absolutely. Coming out 12 inches on a driver's side airbag, right? Position of the seat, Nicole and Steve mentioned that, absolutely. Is the seat far back, far forward, leaning back? So people that ride with the seat back a little bit farther, either they're going to go up and out the windshield or down and under. What do you guys think? Down and under, up and over? I haven't seen a lot of down and under. So let's talk about down and under. We have a motor vehicle accident, frontal impact, and it's a down and under. What's going to be our first impact for our body part?
Legs.
So more specifically, what? The knee, right? So when you take a lot of force, okay, and you hit that object with your knee, where does the energy then transfer to? And what kind of path does it take? And I'm seeing you guys' responses online too, on the chat. Okay? Feel free to unmute. You guys can talk too. It's okay. So the knee is, the energy is then transferred on a path of least resistance to what's going to break next, right? So the femur, Joy, that's even worse. Putting feet on the dashboard. Oh, good Lord. That's femur, pelvis, all that stuff. Right? So that energy is transferred from the knee through a very strong bone, which is your femur, okay? into the femoral head, which goes into the pelvis, right? That's your ball and socket joint that's up there, right? So femoral head, ball and socket into the pelvis, and we have energy that's transferred down through the femur to that pelvis. What's going to happen there? Fracture. So if you have a down and under, suspect pelvic fracture. Don't go, oh my God, their leg's broken. Okay. We can live with a tib-fib fracture. It's not going to kill you, right? A femur fracture has potential, but again, pelvic fractures can kill. How much blood can be kept in a pelvic cavity if we sever an artery?
A lot.
A lot. Love it. Right? Up to about 3 liters of blood. That's half your blood supply can fit in your pelvic cavity. Right? That's a lot of blood. That's shock. That patient's going into shock. They can die from this. That's why it's so important that we stabilize our pelvis on motor vehicle accidents, vehicular crashes and collisions. Right? If they have pelvic pain, we stabilize the pelvis. That is a critical finding. Right? Femur fractures, pelvic fractures, arterial bleeds, those are stuff you find in your ABCs for bleeding control and managing on your rapid trauma assessment, critical findings. Okay? An arm fracture, not a critical finding. A tib-fib fracture, not a critical finding, unless it's open and they're bleeding out. Then it becomes an ABC problem. Does that make sense? Okay, perfect. Assess the vehicle's MOI. If I have a rear end collision, what am I thinking? What kind of injuries am I thinking about? Rear end collision.
Neck injury.
Neck, and what else?
Spine.
Okay. How about brain injury? Could you have a brain injury from a rear end collision?
Sure.
Okay. We're going to talk about, when we talk about head trauma, something called a coop contra coop injury. Think of a walnut in water. A walnut in water. That is your brain. Okay. So if you were to take a walnut, put it inside of a plastic bottle, put some water in it, and then shake it like you had a rear end collision. Shake it back like this. Just give it a quick shake, right? What is that walnut going to do?
Gonna slam up against the walls.
Back and forth, right? That's your coop contra coop injury, causing multiple bruising back and forth, causing internal head trauma. That's your traumatic brain injury stuff. That's TBI. Coop contra coop injury. Right? Neck pain, head pain, multiple contusions inside the brain, right? From a rear end collision. Now, most of the time, it's just whiplash, right? Still, collar them, get them out of the vehicle, do your thing, right? But if they're found to be unconscious, could that coop contra coop injury cause enough damage inside? So again, you got to look at this. If you have a side impact, we think pelvis, femur, right? Potential kidney, spleen, depending on which side of the impact the car is. Rollover is rollover. They're just tossed around everywhere. And rotational spins like that can cause aortic shearing, right? So we got to look at all these different types, T-bone access, and what do we expect to see inside? Anytime you have a vehicle, oh my goodness, let's slow down a little bit. Anytime we have a vehicle collision, there's 3 sources of impact, right? We have the vehicle versus object. And take notes for this, okay? We have the vehicle that hits an object. That's collision number 1. Collision number 2 is you as a person hitting that object, hitting the vehicle. That's collision 2. Collision 3 is your organs hitting your body inside. Remember, they're free floating. They're in there. They're packed there. They're packed where they need to be. Okay? So you have vehicle to object, body to vehicle, organs to body. Those are your 3 collisions in a motor vehicle accident. okay? And then when you have the impact, think about where the patient's sitting and the potential of what those three collisions are going to do. Does that make sense? Okay. So passenger vehicle against the interior of a car. Kinetic energy produced by the passenger's mass and velocity is converted into work of stopping his or her own body. So common passenger injuries include lower extremity fractures, rib fractures, and head trauma. Something has to stop. If something is in motion, it continues in motion until there's a change of direction or something makes it stop, right? What stops you? Windshield, steering wheel, right? Something has to stop. Energy has to be dispersed some other way. Something has to stop you. That's what happens. An outside force, exactly. So a passenger's internal organs against the solid structures of the body is your next collision. Internal injuries may not be as obvious as external injuries, but they are often most life-threatening. Remember, if a solid organ is lacerated because of an impact, that's severe bleeding internally, okay? That's why it's so important to make sure you do an assessment. Palpate, find out where the pain is located, right? If it's a hollow organ, that contents inside the hollow organ is going to leak out and cause severe inflammation and infection. Patients die. All right. So, significant mechanism of injuries are suggested by death of an occupant in the vehicle. If one person's alive and the other person's dead from an impact, and it killed one, you got to consider that patient still critical. The other one, even if they're not showing any signs or symptoms of injury, the impact was bad enough that it killed somebody. Severe deformity of a vehicle or intrusion into the vehicle. And this is not intrusion into the engine compartment, the trunk, right? It's intrusion into where the patient compartment would be, all right?
It's like a guardrail going through a side door.
Yes, that'd be bad. Crashes which involve rotation, where rotation is involved. Remember, shearing effect because of that rotation. Or a patient ejected from the vehicle. Remember, when you go for a motor vehicle accident and there's no one around the vehicle, make sure you look up in the trees because they can be thrown up into a tree and impaled on a branch somewhere. Right? Seen it, been there. Right? Look everywhere, up, down, all around. Even look underneath the vehicle if you can. There could be somebody underneath it. Even though they're not in it, they're underneath it. Right? And don't look just 20 feet away. Look like 50 yards away. Right? Look up in the tree. Like I said, if you're going fast enough, your body can be thrown. It can be thrown at quite a distance. Or they got out of the vehicle and started walking for help and collapsed somewhere in a ditch. So take a look around.
Okay, Kevin, I just want to add also that we went to one where the patient got thrown out of the vehicle. He came out the driver's side window instead of the windshield.
Mm-hmm. Yep, that can definitely happen. Probably non-restrained and thrown out of the vehicle. Be my guess. So evaluate supplemental restraint system that's there. Determine whether the passenger was restrained and whether the airbags were deployed. There are a lot of airbags in the vehicles now, depending on which model, make you buy. Right? So they can be from steering wheel passenger for all vehicles, seat, side impact, curtain, knee bags. I mean, they're everywhere. Everywhere in vehicles now. They have been built into seat belts now. It's insane where they put airbags. Right? And keep in mind the airbags can deploy twice. Right? They're set up for secondary impacts. Some of them are. The newer vehicles, they're called two-stage airbag systems. So got to keep that stuff in mind as well. Make sure that you drain the vehicle of its energy so it doesn't deploy, but keep yourself away from airbags. Last thing you want is for it to go off with you around it. Seatbelts and airbags are effective in preventing a second collision inside the motor vehicle. All right, so airbags decrease the severity of deceleration injuries and decrease injury to the chest, face, and head. All right, people do get burned from airbags, but they can live. However, the airbag detonators do get pretty hot. In a lot of my extrication classes I teach, if I can get a hold of an airbag to deploy, all it takes is the power of a 9-volt battery can actually deploy an airbag. And we've actually cut it open after deploying it and actually fried an egg on its detonator. So it does get pretty hot. They can definitely throw things too. So a lot of power behind them. All right, next. Despite airbags, suspect injuries to extremities resulting from a second collision and internal organs resulting from the third collision, okay? So you got to consider that. Children shorter than 4 foot 9 inches should ride in the rear seat. They really should be sitting up front. In a pickup truck or a single-seated vehicle, the airbag should be turned off. Remember that if the airbag did not inflate during the accident, it may deploy during an extrication. Also remember restraint systems, looking at this picture here. See the red mark going across and around the belly, okay? So you see the seatbelt marks through here. One of the biggest issues we have are people not placing the lap belt in the proper position. They put it up around their stomach, like around their belly button or higher. It has to be down. If you got a gut, pull your gut up, put it underneath it. It's supposed to be around the pelvis and then across the chest. If it goes across the belly, it's going to cause more internal injuries if you get into an accident, if they're not used properly. We're going to look for contact points. So passengers riding in vehicles equipped with airbags but not wearing seatbelts are often thrown forward and come into contact with the airbag or the doors at the time of the deployment. Right? So look for contact points between the patient and the vehicle as you perform a simple, quick evaluation of the interior of the vehicle itself for frontal crashes. Remember that current airbags, they come down about 12 inches or so, and they come out about 200 miles an hour plus. So if you're in there working on a patient and you don't check and make sure those airbags are either been detonated or they're not detonated, if it comes down on your neck, it can break your neck. So just be careful with that as well. Rear end collisions, known to cause whiplash type injuries. This is your coupe contra coupe injuries potential as well. Yes. Yeah, Tondra, exactly. So the rear end collision, as the body is propelled forward, the head and neck are left behind. Accelerating type injuries to the brain is possible. It's that coupe contra coupe injury we talked about. The third collision of the brain within the skull. With lateral impacts, side impacts, which are very common and are cause of death associated with motor vehicles. Now we have intrusion to the actual patient compartment. We don't have a lot of support. All right. I'm having a moment. I can't remember the name of that bar that's in there. If someone remembers in the class, let me know. The bar that runs through the door. I'm drawing a blank of the name of what it's actually called. But it runs on the door here, from here to here. And the tensile strength of those things are unbelievable to the point where a lot of even the newer cutters can't cut through them.
Are you talking about the boron?
What was that?
The boron steel that you're talking about?
Yes, but it's the tensile strength of the steel that runs through the center of the door from, if you're looking at the picture, from here straight back. That protects from side impact, right? One of the problems we've seen with these in motor vehicle accidents and popping the door open, if it's a frontal impact, it takes that bar and it pushes it through so you can't open the door up. And to cut through that will take forever with a Sawzall. And a lot of times it will break your blades on cutters. So just keep that kind of stuff in mind. There is strong, if that bar is broken or dented, that was a severe impact to that side. It's not a Nerf bar. This is something else. I can't think of the name of it. I'm drawing a blank.
I just Googled it. It says anti-instruction bar.
There you go. Thank you. All right. So A vehicle struck from the side is usually struck above its center of gravity. So with that, it begins to rock away from the side of the impact. The result of the passenger sustaining a lateral whiplash injury. Right? Not just lateral impact whiplash, but also pelvis. A lot of people have center consoles, so what happens is your pelvis gets squeezed between them. Right? That can cause a lot of pelvic injuries as well, or any kind of some internal organ injuries as well. Also aortic shearing, because your body's not designed to move that direction of impact. If there is sustainable intrusion to the passenger compartment, suspect lateral chest and abdominal injuries on the side of the impact, possible fractures of the lower extremities, pelvis, and ribs, organ damage from the third collision. Approximately 25% of all severe injuries to the aorta that occur in motor vehicle crash result from a lateral collision, which we just talked about, having an aortic shear because of it. With rollovers, large trucks and sporty vehicles are prone to rollovers because of their high center of gravity. So injuries really depend on whether the passenger was restrained. If they're seatbelt, then they have a higher chance of survival. The most unpredictable types of injuries are caused by rollover crashes in which a passenger is unrestrained. So the most common life-threatening event in a rollover is ejection or partial ejection of a passenger of the vehicle. Even when restrained, passengers still can sustain severe injuries, especially if their windows are open. Their arms can come out and they can be crushed, things like that as well. Just something to think about. Rotational crashes or spins are conceptually similar to rollovers, but instead it stays on all four and just kind of spins in circles. It allows the vehicle to strike other objects such as utility poles and things like that. Injuries are often graphic and apparent, right? But there are a lot of unseen injuries as well, so you need to make sure you do a rapid head-to-toe assessment. You should really determine the speed of the vehicle, how fast were they going, whether the patient was thrown through the air or not, the surface the patient landed on, whether the patient was struck or pulled underneath a vehicle, or were they ejected and struck by another vehicle. Right, so keep a high index of suspicion for unseen injuries of those. Right, so car versus pedestrian. We're going to evaluate the vehicle that struck the patient for structural damage. An ALS backup should be summoned for any patient who has sustained a significant MOI. ALS backup allows for fluid replacement and pain management. Okay. Also, the potential for decompression and airway management above and beyond what the basic level can do. All right. So evaluate like you would for a car versus pedestrian collision. If there's like a car versus bicycle. Same thing. We talked about that, turning away versus turning towards the kids, moving with a bike. Same thing, full assessment. Evaluate the MOI in the same nature. Evaluate the damage in the position of the bicycle. And if the patient was wearing a helmet, inspect it for damage. Take the helmet with you. All right. Bring it with you to the hospital so the doctors can see it. If you got take pictures of the bike and bring them with you on your phone and show the doc. That is okay to do. Just delete stuff when you're done. You can also take the pictures that you take of the helmet of the bicycle. And nowadays, everything being electronic PCR for reports, you can attach these to your reports as well. All right, so presume that the patient has sustained an injury to the spinal column or spinal cord until proven otherwise at the hospital. So maintain spinal mobilization. Place your cervical collar on the patient. Protection. Yeah, if they have a helmet on, leather or abrasion-resistant clothing, boots. These will protect you against road abrasions, but not blunt trauma or secondary impacts. All right. Helmets do not protect against cervical injury, severe cervical injury. Boots, collision usually occurs as well. Excuse me. Against larger vehicles or stationary objects. So in assessing the scene, car versus motorcycle, look for deformity of the motorcycle, side of the most damage, distance of the skid in the road, deformity of stationary objects and other vehicles, and extent and location of deformity in the helmets to determine head injury. There are 4 types of motorcycle impacts. Head-on crash, where the motorcycle strikes another object and stops it forward motion, while the rider continues his or her forward motion until stopped by an outside force. What kind of injury would you suspect with that? Motorcycle goes up and over.
Spinal.
Okay, spinal injury. What else? Abrasions. Connor said neuro.
Wrist fractures.
Yep. How about pelvic? Femur. Right? Would you guys suspect the femur fracture on those? All kinds of breaks and boo-boos. Absolutely. If a patient hits something, if a motorcycle hits something head on, okay, depending on what type of bike there is, you're going to go up and over, right? Most likely it'll be up and over the handlebars. What's going to stop you from going over the handlebars initially? Your legs.
Yeah, maybe your feet catching the handlebars.
Yeah, or your legs. And that'll snap your femur. Pelvic fractures, if you get caught in the pelvis, right, and you pull, you're going to fracture something. So just be aware. Motorcycle crashes, person down on the ground, you may have unstable pelvis. You may have fractured femurs, right? So, again, all kinds of breaks and boo-boos. Love it. All right, angular crash. Motorcycle strikes an object at an angle so the rider sustains direct crushing injury to lower extremity. Rider will travel to a high rate of speed until stopped by a stationary object, severe ejections. Severe abrasions can also occur with this road rash, or a controlled crash where they know they're going to go down, they lay their bike down. All right. So keep in mind of abrasions and a road rash from those. That's going to require a lot of cleaning, very painful scrubbing and cleaning. Yeah, it's pretty crazy, Tanya. You just wrote down there. You guys can read her story about a call that she went on her chat box. It's interesting. That's a good pickup though too. You know, look for those kind of things.
Eric and I, when we got to the call, Conway was dispatched as a secondary because we had 2 victims. The male was about 20 feet away from the bike, but the female passenger was only about 5 feet from the bike. And what struck me when I first saw the female was that her tongue was so swollen, it was coming out of her mouth. She had a compound fracture of her right humerus with no blood. So that told me that she was killed on impact. And they still hooked them both up to the monitors to do, I believe they did a 4 lead on both victims to double check. But when they went to move the male, his brains came out, despite them both wearing half helmets.
Yeah, that's pretty interesting. All right, so how do we feel about motor vehicle stuff? take home from all of this, all right, look at the mechanism. All right, you hear a lot about mechanism of injury, and people said, oh, well, we don't have to follow mechanism as much anymore. I've been doing this for a while, and I still, to this day, look at mechanism of injury. I think it plays a huge part on what potentially could be wrong with your patient. So look at it, okay? All right, falls. So injury potential depends on the height of the foot which the patient fell. More than 20 feet is considered significant. So a lot of times they usually say twice the height of the patient. Internal injuries pose the greatest threat to life with these. So once again, patients that fall and land on their feet have less severe internal injuries, but their legs have absorbed so much of the energy of the fall, right? So where is the energy being transferred to? Energy tries to find the path of least resistance, okay? So with her landing on her feet, so it says calcaneus down here at the end of the heel, energy is transferred up into the pelvis. A lot of times they can fall and they can have a pelvic injury. So take into account the height of the fall, the type of surface it struck, and the body part that hit first, followed by the path of energy displacement, which would be the path of least resistance. Penetrating trauma. Second leading cause of trauma death after blunt. So low energy penetrating trauma may be caused accidentally by impalement or intentionally by a knife, ice pick, or other type of weapon. Many times it is difficult to determine the entrance and exit wounds from projectiles in a pre-hospital setting. It's hard for us to kind of predict it. Determine the number of penetrating injuries that are there. It can be multiple stab wounds of some sort. Combine that information with the important things you already know about the potential pathway of penetrating projectiles. So once again, you need to know where the organs are located within your body, because if you have an impalement of some sort or a penetrating trauma, you need to have an idea of where they may have gone and what it may have struck. So with low energy penetrations, injuries are caused by the sharp edges of the object moving through the body. So knives have been deliberately moved around intentionally, causing more damage than an external wound would suggest. We're trying to determine the length of the penetrating object, so the length of the blade, right? As far as the path of the projectile, may not be easy to predict. So again, a bullet may ricochet within the body before exiting. That's why you want to try to find that exit wound, or is the bullet still lodged somewhere within the body? So the path of the projectile takes its trajectory as we see, and then fragmentation will also increase the damage. So I'll show you guys on the next slide here. So the bullet speed is another factor also in the resulting injury pattern. So looking at here, cavitation. The cavitation results from rapid changes in tissue and fluid pressure that occurs within the passage of the projectile. So as you can see down in the picture here, as we enter in, reformation of laxative tissue, temporary cavity is in the blue, and the permanent cavity is one of the orange, directing right through. Okay. All right. So the relationship between distance and the severity of the injury varies depending on the type of weapon involved. Right. So air resistance, often referred to as drag, slows the projectile down, decreasing the depth of penetration and the energy of the projectile, and thus far reducing damage to the tissues. The area that is damaged by medium and high velocity projectiles is typically many times larger than the diameter of the projectile itself. This is one reason that exit wounds are often many times larger than an entrance wound. Right? So the energy also available from the bullet to cause damage is more of a function of its speed than its actual mass. So any information regarding the type of weapon that was used should be revealed to medical control. So find out the type of gun that was used along with the bullets that were used with it and let them know. Right? They need to know this information. So this table here shows signs of developing problems in trauma patients. Literally cannot read it. All right, so let's go to blast injuries. So the most common in military conflict, also seen in mines, shipyards, chemical plants, and terrorist attacks. So this slide shows you the 4 mechanisms of a blast injury. I'm going to go over those in a second, more in detail. All right. So the next slide here. So primary blast injuries due entirely to the blast itself, which then cause damage to the body, which is caused by the pressure waves generated by the explosion. The secondary blast injury is damage to the body resulting from being struck by flying objects. And then the tertiary blast injury is the victim where they are hurtled by the force of the explosion against a stationary object. So all right, so we go back one here. So injuries due to the blast and the wave initially goes off, right? Right. Then you have a secondary injury caused to being propelled by the blast force. Tertiary injury due to the impact with another object hitting. Then we have our quaternary injury, which is our miscellaneous blast injury, which then would be burns from the hot gases or fires started by the blast, respiratory injury from inhaling toxic gases, crush injury from the collapse of a building, or something collapsing on top of you. All right. Then suffocation, poisoning, or other medical types of emergencies that come with it. So contamination of the wound from the environmental chemical or toxic substance is another one. Most patients who survive an explosion will have some combination of these 4 types of injuries mentioned that are here. If it's a crush injury, we have to play that very closely with ALS because we need cardiac monitoring and specific medications so we don't release toxins to the entire body for crush injuries. If it's something with respiratory toxic gas or inhalant, they may need to be intubated quickly. So have ALS coming to assist with that. Organs that contain air are most susceptible to pressure changes, like the middle ear, the long gastrointestinal tract. So the ear is the most sensitive to a blast injury. So junctions between the tissues of different densities and exposed areas, such as the head and neck tissues, are prone to injury as well. All right, remember I mentioned the ear being the most sensitive because the tympanic membrane evolved to detect minor changes in pressure and will rupture at pressures of 5 to 7 pounds per square inch above atmospheric pressure, which is why people have a hard time hearing after an explosion. So the pulmonary blast injuries result from a short-range exposure to the detonation of an explosive. So the primary blast injury is often characterized by a lack of external visible injuries. So other injuries potential can be pneumothorax, which is a common injury and may require emergency decompression in the field, which is a paramedic skill. Pulmonary edema may ensure rapidly as well. One of the most concerning pulmonary blast injuries is arterial air embolus, which occurs on alveolar disruption with subsequent air embolization into the pulmonary vascular, which can produce disturbances in vision, changes in behavior, changes in the state of consciousness, and a variety of other neurological signs. So we got to make sure we're paying attention for that for blast injuries. Solid organs are relatively protected from shock waves, but may also be injured by secondary missiles or a hurled body. So the projectiles from the blast. Neurological injuries and head trauma are the most common causes of death from a blast injury. And one of the things we'll usually see is a subarachnoid or a subdural hematoma, which are often seen. Bradycardia and hypotension are also common as well. So extremity injuries include traumatic amputations are also very common with an explosion, a blast type injury. All right, any questions so far? You guys doing okay?
All good. Thanks.
Awesome. Perfect. All right, so multisystem and trauma involves more than one body system. Head and spinal trauma, chest and abdominal trauma, chest and multiple extremity trauma. You must alert medical control and transport rapidly. They need to know this, right? And we want to get these patients, right, as soon as we can to a trauma center. So your main priority is to ensure your safety, the safety of the crew, the safety of the patients, determine the need for additional personnel or equipment, and then evaluate the mechanism of injury. So identify and manage life threats, then focus on patient care. So we're going to assess and manage the airway. Airway is priority with these, unless they're bleeding out. Okay, then we got to stop bleeding. Ensure that basic shock therapy is completed. So lying them down flat, supine, right? Elevating the legs if needed to Trendelenburg position, applying oxygen to the patient and keeping them warm. Protect the spine and proceed with spinal immobilization if indicated using a cervical collar. Then we're going to transport the patient immediately to an appropriate facility. And these patients here need to get to trauma centers. So definitive care requires surgical intervention. So who can handle cervical intervention for these patients? So on-scene time should be limited to 10 minutes or less. Right? We got to transport rapidly. During the transport, obtain a sample history and complete a secondary assessment. All right, and then consider ALS intercept or air medical transportation. So when this is over, I'm going to bring up the DART video. I got to find it. I'll play it for you guys so you can see it on air medical. All right, so let's talk about patient assessment. Patient assessment consists of size up, primary assessment, history taking, secondary, and reassessment, right? We've hit that a lot. When you are caring for a patient who experiences a significant MOI and the patient is considered to be serious or critical condition, you should rapidly perform a physical exam. That's your rapid head to toe, 60 seconds, touch everything, right? When the patient has experienced a non-significant MOI, focus on the chief complaint while assessing the patients as a whole, right? So if you feel the need that you need to do a rapid, then do a rapid on these patients, okay? We go through everything. All right, so injuries to the head, disability and unseen injury to the brain may occur. Remember we talked about the coop contra coop injury going back and forth, right? And we're going to cover more about head and the spine when we get into that chapter. Bleeding or swelling inside the skull is often life-threatening, okay? Our skull is not meant to bleed internally. It's not meant to put any more pressure than what's already there. Increased cranial pressure can cause significant injuries. And we're going to talk about Cushing's triad, right? We talk about head injuries later on in another chapter and what to look for and how to pick up on Cushing's. Some patients will not have obvious signs or symptoms until minutes or hours after the injury occurred. If they have a head bleed, it may take hours for them to get to a point where they start developing more symptoms, like a significant headache, right? Confusion, altered mental state. It could take hours or it could be minutes, depending on the size of the injury, right? So injuries to the neck and throat, this is an area of serious or deadly injury. So the trachea may become torn or swell. If that's the case, then we no longer can pass air through. Airway problems may result that could quickly become a serious life threat. So if you have anything with a neck or throat injury, having ALS on board that have the ability to put tubes down throats if needed might not be a bad option to have with you. But be able to pick up on that by doing an assessment and actually feeling for it. Feel the trachea. Is it midline? Okay. Or is it deviated? Is it crushed? You'll be able to feel it just by palpating. Your assessments also include frequent physical examinations looking for decap BTLS, right? Remember, deformities, contusions, abrasions, puncture, penetration, burn, tenderness, laceration, swelling. Also assess jugular vein distension and tracheal deviation as well. Tracheal deviation, trachea deviates to the side that actually works. Tracheal deviation is a very, very late sign of a pneumothorax. Right? Jugular vein distension means that there's a backup in the system of the heart. A lot of times you'll see pericardial tamponade you'll see with this, right? So there are three things you need to look for. If I said Beck's triad, would you guys know what I'm talking about? BECKS, Beck's triad. Yeah, cardiac tamponade. What are the three things? What are the three signs and symptoms that you're going to listen to or see to meet Beck's triads and know that patient has cardiac tamponade?
Is jugular vein distension one of them?
It is. There's one. Got two more.
Low blood pressure.
Say it one more time.
Low blood pressure.
Not necessarily low. You're close. So muffled heart sounds from Nick. All right. And I'll go with your blood pressure, but it's called narrowing pulse pressures. So what you're going to find is your systolic and diastolic numbers are very, very close together. So like 90/88. Because your heart can no longer pump because you have inflammation, right? I should say swelling around the heart. The only way to relieve this, okay, for Beck's triad or pericardial tamponade is something called a pericardial synthesis, where they take a very, very long needle, they put it through your chest wall into your heart, right, in the pericardium, and they pull the fluid out. Not a skill that medics are trained to do, okay? This is done by a surgeon, and it's also guided by ultrasound, right, so they don't miss anything and go in the wrong part. So you might see this in a quiz again, Beck's triad, all right? So I'm gonna type it out, JVD. Okay, that's the three things. That's triad. You guys can go back and write that down later. So those are three things you need to pick up on. And we'll talk about Cushing's during head injuries. I'm not going to get too much into these you guys today for that one there. All right, so a penetrating injury may result in an air embolus. Right? Our body is not meant to take air other than going through your lungs. Okay, so if you have an air embolus. So use an occlusive dressing to prevent this from happening. Right? And we'll talk more about occlusive dressing when we talk about injuries to the head, neck, and spine, and chest injuries as well. A crushing injury to the upper part of the neck may cause cartilage of the upper airway and the larynx to fracture, therefore making it very difficult for someone to breathe. So injuries to the chest then contains the heart, remember the heart, lungs, and large blood vessels. This may be life-threatening as well. Broken ribs may hinder breathing. Multiple broken ribs is something called flail segment. We have two or more broken ribs in a row. That can also puncture the lung, causing a tension pneumothorax. So bruising may also occur around the heart and cause an irregular heartbeat. We talked about pericardial tamponade. Large vessels of the heart may be torn inside the chest, causing massive unseen bleeding. That's going to be our aortic shearing. Air may collect between the lung tissue and the chest wall, known as the pneumothorax. Another one is something called subcutaneous emphysema. Okay, so subcutaneous emphysema is up by the clavicles and lower, and what you're going to do is you're going to palpate it, and it literally will feel like you're crushing Rice Krispies underneath the skin. It means we're starting to get air trap. Air trapment, subcutaneous emphysema, or air trapping, can cause potential for a pneumothorax. You want to be able to pick up on that when you're assessing. A penetrating or perforation of the integrity of the chest wall is called an open chest wound. If left untreated, shock or death will result. So it is imperative that you assess the chest region every 5 minutes. And it should include decap BTLS, lung sounds, and chest rise and fall. If the patient loses their lung sounds and they become absent, we may have potential for a pneumothorax. You'll see irregular respirations. You'll have absent lung sounds or very, very diminished lung sounds. On the side that's collapsed, you'll have decreased pulse oximetry. The very late sign is tracheal deviation. Injuries to the abdomen. The abdomen contains, remember, vital organs that require a very high amount of blood flow to perform its functions necessary for life. The organs of the abdomen and retroperitoneum can be classified in 2 categories, solid and hollow. Your solid organs, again, include the liver, the spleen, pancreas, and kidneys, as your hollow organs include the stomach, the large and small intestines, and the urinary bladder. So when these injuries from trauma occur in this region of the body, serious and life-threatening problems may occur. So solid organs may tear, lacerate, or fracture, which can cause serious bleeding into the abdomen. Hollow organs may rupture and leak toxic digestive chemicals. The patient will eventually develop a life-threatening infection. They can become very septic, and they can die from this. The rupture of a large blood vessel can cause serious unseen bleeding. That would be your aorta. So reassess the abdominal region using decap BTLS. So management and transport and destination. So again, call for ALS and helicopter assistance early to avoid delays in treatment and transport. Survival of critically ill trauma patients is time dependent. We talk about the golden hour. 1 hour from the time the time you arrived on scene when the incident happened, to get in the patient to definitive surgical care. All right. So you'll hear in other books, Platinum 10, Golden Hour. The Platinum 10 is the first 10 minutes on scene, making a decision, getting the patient out. The Golden Hour is the time the injuries occurred, the time they get surgical care. So the following criteria will help you to identify a critically injured patient: a dangerous MOI, decreased level of consciousness, or threats to the airway, breathing, or circulation. So the type of transport: ground EMS units are staffed by EMTs and paramedics. Okay. Air EMS, critical care transport units, are staffed by critical care nurses and paramedics. And they also carry other things like blood products, right, which can be very beneficial to a patient who has traumatic injury. Right, so the Association of Air Medical Services and Medevac Foundation International identify the following criteria for the use of air medical transport in trauma patients. Is there an extended period required to access or extricate a remote or trapped patient? The distance to the trauma center is more than 20 to 25 miles. The patient needs ALS care and there is no ALS level ground ambulance service available within a reasonable time frame. Traffic conditions in the hospital availability make it unlikely for the patient. And the patient will get to a trauma center by a ground ambulance within an ideal time frame. There are multiple trauma patients who will overwhelm the resources of the nearby trauma centers. All right. So those are some things to think about. Multiple trauma patients and mass casualty incidents. Which we have an entire chapter for. So a level 1 facility serves large cities or heavily populated areas. Provides every aspect of the trauma care and usually university-based hospitals. Right? There's only one level 1 facility in the state of New Hampshire, and that is Dartmouth-Hitchcock. There's only one in the state of Maine, and that is Maine Medical Center. Right? Massachusetts has quite a bit. They have quite a few level 1 trauma centers down there. Right? Level 2 facility is located in less population dense areas, provides initial definitive care, like Portsmouth Hospital being a level 2. Level 3 provides assessment, resuscitation, emergency care, and stabilization, and transfers patients to level 1 or level 2 facilities when necessary. And level 4 facilities found in remote outlying areas provides advanced trauma life support. Those would be like your Huggins Hospital, Memorial, things like that, that are what they call critical access hospitals. So they have access to bigger centers. So trauma centers are categorized either by adult trauma or pediatric trauma. So please do not take a pediatric trauma patient to an adult trauma center when a pediatric center is available. We do not have that availability up here. So our Maine Medical Center, Dartmouth, they take peds and adults. When you get down in the Boston area, it's a different story. All right. So as far as transport and destination special considerations, remain calm, complete and organized assessment, correct any life threats, do no harm, never hesitate to contact ALS backup or medical control for guidance. Let's go over this here, then I'll bring up the video for you guys, and then we'll get started with that. And then we'll take a break for 10 minutes, come back to the last chapter, and we'll be done. Kinetic energy is a calculation of what? All right, the answer is B. Kinetic energy is a calculation of mass and velocity. Remember, energy cannot be destroyed, only converted. Number 2, a 20-year-old man has a major open facial injury after his vehicle struck a tree head-on. Which of the following findings within the car would most likely explain the injury pattern? All right, C it is, the windshield. Which of the following would most likely result from the third collision in the three collision effect that occurs during a high-speed frontal impact vehicle crash? All right, D it is. Good job. Number 4, a young male experienced severe blunt chest trauma when his passenger car struck another vehicle head-on. During your inspection of the interior of his vehicle, you would most likely find all right, we're seeing a lot of B's pop up. Perfect. All right, nice job. B it is. Number 5, an unrestrained driver collided with a bridge pillar. Upon inspection of the interior of his vehicle, you note that the lower dashboard is crushed. During your assessment of the patient, you will most likely encounter
A.
It is. Whiplash injuries are most common following what type of impacts?
Oh, yeah.
A.
A. It is. Number 7, death from a rollover motor vehicle crash is most often secondary to. Death from a rollover.
And the patient first. D.
All right. The answer is D. Number 8, severe abrasion injuries can occur when motorcycle riders are slowed after a collision by a road drag. Road drag is most often associated with which type of motorcycle impact?
D.
So this is a tough one, because you would think controlled drag, you would have it. But they're going with ejection, C. So that's a tough one. This would be like a national question right here. So I've seen plenty of, either way the rider separates from the bike. It's true. Number 9, when assessing a stab wound, it is important for the EMT to remember that. All right. D it is. Number 10, a 40-year-old man was standing near a building when it exploded. He has multiple injuries, including a depressed skull fracture, severe burns, and an impaled object in his abdomen. His head injury is most likely caused by what blast injury? Which one would it have been? So, Joy, to answer your question with the ejected part, is you were on the vehicle itself, the motorcycle, and you were taking off, and they consider that an ejection. But it is a good question, though. All right, tertiary injury. All right, so I'm going to stop the recording just for a moment here. I got to go to YouTube and TV.
This conference will now be recorded.
DART is the only helicopter EMS within Vermont, New Hampshire.
We provide a service like few others across the United States.
We have the equipment and the training to handle life support missions.
We take care of the most sick and most badly injured patients, and to be able to help those people on a daily basis is incredibly rewarding.
Now I click on
Chapter 1, modified medical center.
that's us. We're on our way, and the plan right now is to land at your facility for a head injury coming out of surgery. We should be landing in about 10 minutes. If that changes, I will certainly let you know, okay?
As soon as we get the call, we move out to the helicopter and we like to be off the ground in under 5 minutes.
Once we get the mission activated and the vehicle leaves here, then our primary function turns into keeping track of that vehicle. All of the programs in the Northeast belong to a fleet eyes, which is keeping track of where the aircraft are all the time to keep from running into each other.
DART provides critical care transport when time is going to make a difference in the outcome of the patient.
We bring the hospital to the patient and continue that level of care till they arrive at the receiving hospital.
I like to describe DART as an outstretched hand, extending the reach of DH and the quality care that is known for our organization.
the DART program really stresses safety. They have all the safety features on this aircraft. They have all the rules in place. And so that to me speaks to the desire for Dartmouth-Hitchcock to provide a safe environment, not only for the people that work for them, but also for the patients that we're moving around.
Yeah, Daryl, once about 5 minutes for landing at the agenda, I think there's no. It's a fantastic resource and it gets us to the patient in the most appropriate, safe way.
DART was the brainchild of a number of individuals here at the hospital who saw the need to have a helicopter transport service based here at Dartmouth-Hitchcock Medical Center to transport patients from the rural regions of both New Hampshire and Vermont.
My interest in the DART program came up the day it was born because I was in the military at the time and I heard, hey, they're starting a helicopter program in the place that I wanted to retire.
It was in development for a couple of years before July 1st, 1994, which is the day that DART went into service.
And once it got going, it became quite obvious that every year you have more and more patients to move as more and more people become aware of the service.
Now we have transported just slightly over 24,000 patients by both helicopter and by ground ambulance.
The vast majority of our missions are to rural hospitals and back here. Clearly, the most fun are when you go up into the mountains and you have to find some little tiny space to land or put the skids down on the uneven rocks.
To be able to land somewhere pretty remote is pretty challenging and very exciting. People will first notice that it is quite small inside the aircraft. Everything that we have is within arm's reach, and so we can always pass equipment back and forth to each other. We have an array of equipment that makes it more like a flying intensive care unit. One of the new pieces of equipment that we carry is a portable iStat, which can get the complete readout on the patient's blood chemistry through a drop of blood that we process through this machine. The red bag we consider kind of our primary bag. And one of the things in the top of our red bag here is a video laryngoscope that helps facilitate placing a breathing tube into a patient. We carry 3 units of O negative blood, and we transfuse blood to our critically injured patients. We have it. If the patient needs blood, we can deliver it in the aircraft. It can be a life-saving intervention in the field. So really, there are benefits in working in an environment that is smaller like this. This is a good size for what we do, and as you can see, it's pretty well equipped.
The aircraft are operated by Metro Aviation. So every time we take off, Metro headquarters in Shreveport is authorizing that flight. And they look at every single takeoff and they monitor our progress throughout the flight. And they also handle all of the mechanical issues with the aircraft and all of the normal scheduled maintenance.
DART's ground team provides the same level of service that we do by air.
They often back me up. They will do the time-sensitive critical care transports that I can't get to.
There's no delineation between the level of care you would get from the helicopter or from the ground unit.
One of the things we are challenged with is the enormous differences in weather. We fly in all sorts of weather that can change throughout the day, let alone the week or the month.
We have implemented a number of safety features, not only to the staff in the helicopter, but then also the patients that they're caring for.
First, they switched the type of aircraft to the EC-135.
We have added a new base in Manchester, New Hampshire with a second aircraft.
We also added night vision goggle capability, which greatly enhances our safety margin because we can now see the mountains looming out there in the darkness. And then we added terrain awareness that will set off an alarm if you get too close too fast. And then finally, traffic awareness, which looks for other aircraft around us. So some great safety advantages that expanded our ability to conduct missions in poorer weather.
We're the first in the nation GPS approaches into various hospitals and helipads and various navigation routes.
It's low-level IFR, instrument flight rules, hospital to hospital, so we don't necessarily have to have an approach from airport to airport, primarily in New Hampshire and Vermont.
We can go to all of our local hospitals and local landing zones to get patients where other times weather in the past may have precluded that.
Start to be just a moment on the ground here. Take off.
Training that we have and the equipment that we carry, and ultimately the speed of the helicopter is what certainly saves lives, and it makes me very proud to be associated with such a great team of people.
I feel like I'm living my purpose by being able to positively impact other people's lives.
Having a group of individuals that's ready to go at a moment's notice for whatever they're called to is very, very rewarding. I'm impressed by what we are able to accomplish each and every day.
Tower one's about 9 miles to the south.
This conference will now be recorded.
All right, so we're going to cover chapter 25, bleeding control and bleeding. So some stuff's going to be review. So I'm not going to hit hard on the A&P stuff, as we've already covered it enough, I believe, through cardiovascular and whatnot, but kind of how blood works and move from there. All right, so again, national competencies being met, talking about bleeding control and recognition and management of bleeding and pathophysiology of bleeding as well. And we're going to apply the fundamental knowledge, of the pathophysiology of respiration and perfusion to a patient assessment and management. All right, so it's important to be able to recognize bleeding. All right, so you got to be able to pick up on this, look at it, doing on your primary assessment under ABCs. Right, you got to look for the body for bleeding. So after managing the airway, recognize bleeding and understanding how it affects the body are the two most important skills you'll learn as an EMT. Bleeding can be external, which is obvious, or internal, which is hidden. Either way, either type of bleeding is potentially dangerous and can cause weakness, shock, or death. Uncontrolled bleeding is the most common cause of shock following a traumatic injury. So anatomy and physiology of the cardiovascular system, I'm not going to go into this very in depth, but the cardiovascular system circulates blood to all of the body's cells and tissues, right? So it delivers oxygen and nutrients, carries away metabolic waste products, and responsible for supply and maintaining adequate blood flow. 3 parts. You gotta have the pump, which is the heart, the container, blood vessels, and fluid, blood and bodily fluids. You have to have these 3, right? Remember that the body needs 3 things to survive. That's fluid, so blood, right? Oxygen and sugar. Take one of those 3 away and the body dies. So with the heart, you need a rich, well-distributed blood supply. This works as 2 paired pumps. There's an upper and the lower chamber, atrium and ventricle. All right. Number 1 pumps blood into the next. It goes around and around the body. It goes back into the heart again from right atrium to right ventricle, through the lungs to left atrium, left ventricle to the body. All right. Blood leaves each chamber through a one-way valve. Right. There's 4 valves within the system, as we can see looking at this picture here a little bit better. We have the tricuspid, pulmonic, mitral, aortic valves. Those are the 4 valves, one way that pumps blood through and it can't pass back through the other direction, right? Remember, it starts off as deoxygenated blood in the right side. As it passes through the lungs into the alveoli, carbon dioxide is expelled, oxygen is brought back in, goes through the left atrium, the left ventricle, and pumps oxygenated blood throughout the body. Arteries carry blood away from the heart. Arterioles, remember, they're smaller vessels that connect the arteries to capillaries. Capillaries pass along the cells and link arterioles and venules. All right. Again, I'm not going to hit this stuff too hard. We've gone over this quite a bit already. More of just a review. As it goes through the capillary bed, it then comes through the venules, which are very small, thin-walled vessels that empty into the veins, and the veins then carry blood from the tissues back to the heart. And the veins are done through a valve system to build up pressure to push through. Remember, arteries have a lot of pressure, veins do not, so you have to have a buildup with one-way valves going through to get that blood back to the heart deoxygenated. So oxygen and nutrients easily pass from the capillaries into the cells, and the waste of the carbon dioxide diffuse from the cells into the capillaries. This transportation system allows for the body to rid itself of the waste product, right? So we're done through diffusion, taking the bad stuff in, pushing the good stuff out. That way everything becomes perfused. If we have a lack of red blood cells, we have a lack of oxygen. A lack of oxygen then turns into inadequate state of tissue perfusion. The adequate state of tissue perfusion then turns into shock. So blood contains red blood cells, which are responsible for transportation of oxygen to the cells and transporting carbon dioxide away from the cells back to the lungs, as you can see here. Right? The blood also contains white blood cells, which are responsible for fighting off infection. We have platelets that are responsible for forming blood clots, which is what we want to happen, but not overproduction, and plasma, which is the fluid portion of the blood that's actually there. So blood clot formation depends on several factors. One is blood stasis. Changes in the blood vessel walls, such as a wound, and blood's ability to clot affected by disease or medication. So what they're saying here is that you may have factor issues within your system that make it so that we're there, you can no longer clot very well. So hemophiliacs, patients that can't clot, they just continuously bleed. Right? A lot of times it's factor 8 that they're missing with those. The other issue would be patients that are on blood thinners, like not heparin, Plavix, things like that, warfarin, Coumadin, right? That are taking the ability of clotting away. So red blood cells, when the tissues are injured, platelets begin to collect at the site of an injury. Red blood cells become sticky and start clumping together. Then protein in the plasma reinforces the developing clot and the bleeding stops. Right? If we do not have that ability, the patient can bleed out. So these are the autonomic nervous system. This kind of plays a big part of this as well. The autonomic nervous system monitors the body's need for movement to, body's need for movement to movement, adjusting blood flow by constricting or dilating vessels, which then automatically redirects the blood away from the organs of the heart, brain, and lungs, and kidneys in an emergency, which then adapts to changing conditions in the body to maintain homeostasis and perfusion. Right? So we want to make sure we're having good perfusion, good oxygenation, to make sure that our tissues are perfused appropriately so we don't go into shock. We got to meet that homeostasis level. That's like our even playing ground. If the system fails to provide sufficient circulation for every body part to perform its function, then shock results, and then we're going to start seeing the changes. So with pathophysiology, perfusion is the circulation of blood within an organ or tissue in adequate amounts to meet the cell's current needs for oxygen, nutrients, and waste removal. So if we have a laceration, if we are bleeding out, our body is going to compensate by increasing our heart rate, increasing our respiratory rate, right? So we're going to bring more oxygen in, and our heart's going to pump faster to get the cells perfused. But that can only go on for so long before the body gets too tired and goes decompensated, which we'll talk about in a little bit. So the speed of blood flow must be fast enough to maintain adequate circulation throughout the body to avoid clotting. Right? We don't want clotting to happen until it is needed to happen. Right? So it must be slow enough to allow cells time to exchange oxygen and nutrients for carbon dioxide and other waste products. So some tissues need a constant supply of blood, while others can survive with very little. So all organs in the organ system of the human body depend on adequate perfusion to function properly. Every organ requires something, but some cannot tolerate the interruption of blood for even a few minutes without sustaining any kind of damage. So death of an organ system can quickly result in death of a patient. Okay, we need to make sure that organ systems are functioning appropriately. Emergency medical care is designed to support adequate perfusion until the patient arrives to the hospital, whether that be giving oxygen, applying a tourniquet to stop a major bleed, to ALS care by providing more fluids and replenishment. So the heart requires a constant blood supply. The brain and spinal cord may last up to 4 to 6 minutes without perfusion. That's not a very long time, right? You have to have perfusion. If the heart doesn't pump, the brain will die eventually. The lungs can survive only 15 to 20 minutes without perfusion. Kidneys, 45, skeletal muscles, 2 to 3 hours. Gastrointestinal tract can tolerate slightly longer periods. These times are based on a normal body temperature of 98.6. The colder the temperature will lengthen survival times, which is why patients in cardiac arrest, they talked about therapeutic hypothermia by freezing the body, to slow the body down, to allow them to better perfuse over a longer period of time. Patients are getting pulses back from cardiac arrest. So external bleeding, bleeding we can see, right? And so a hemorrhage means bleeding, external, visible, so like nosebleeds, bleeding from an open wound or fracture of some sort, things that we can see outside of the body. Those would be more of our signs, not symptoms, right? So with a serious external bleeding, it may be difficult to tell the amount of blood loss. Blood will look different on different surfaces, absorbed in clothing versus diluted in water, concrete versus pavement, grass versus dirt. A lot of stuff will make it look different. So it's very hard to estimate roughly about how much blood is actually lost. So right now, I'm holding in my hand, and you guys really can't see it, is a bottle of Vermont Pure Water. And it says 500 mLs. This bottle that I'm holding is about the total amount of blood in a pediatric, in an infant. That's it, what I'm holding in my hand. 500 mLs, half a liter. That's not much at all, is it?
No.
I hit the wrong button, I apologize. Let's skip around over here. So, let's see. Somehow I turned on.
Closed caption for the hearing impaired.
Whoa, this is interesting. I don't know how I did that. Honestly, I have no idea. All right, let's go with it. So I'll fix up my my voice with a stuffed up nose. So the significance of external bleeding, with serious external bleeding, it may be difficult to tell the amount of blood loss, which we talked about, right? It looks different. Treatment should be based on the patient's presentation and the mechanism of injury. So the body will not tolerate an acute blood loss of greater than 20% blood volume, which is about 2 pints. Typically, the adult male has approximately 70 mLs of blood per kilo of body weight. So go ahead and let me know how much blood do you guys feel you have in your system. So you want to convert it, right?
Two to 3 liters.
Okay. So what you do is you take your body weight in pounds, divide it by 2, and take off 10%. Or if you have a calculator in front of you, divide your body weight by 2.2. Then multiply that by 70, and that will give you your amount of typical blood per kilo body weight. And then a female has approximately 65 mLs. So kind of interesting information. You guys know how much blood you have in your body roughly. So adverse changes in vital signs may occur with significant blood loss. Like I mentioned before, we're going to see increased heart rate, increased respiratory rate, because we want to make sure our body is being perfused. So it's a mechanism of compensation, right? Decreased blood pressure, we're starting to get into decompensated shock at some point, right? We'll either see normal tension or maybe hypertension initially, but eventually that will change into being hypotensive, lower blood pressure. Because infants and children have less blood volume to begin with, the same effect is seen with smaller amounts of blood. The only difference is children can compensate more than adults can. But when they decompensate fast versus an adult, we'll start seeing those vital signs changes. So how well people compensate for blood loss is really related to how rapidly they bleed. An adult can comfortably donate 1 unit of blood, 500 mLs of blood, over a period of 15 to 20 minutes, and you're perfectly fine. Right? If a similar blood loss occurs in a much shorter period of time, the person may rapidly develop symptoms of hypovolemic shock. The age and pre-existing health of the patient should also be considered. Right? So young children versus elderly. So blood loss is an extremely serious problem that demands immediate attention before airway and breathing are even addressed, because when we lose blood, the body can no longer function. Other characteristics of bleeding, external bleeding, will be injuries with some illnesses can disrupt blood vessels and cause bleeding itself. So you should consider bleeding to be serious if the following conditions are present: a poor general appearance and no response to external stimuli, signs and symptoms of shock or hypoperfusion, so hypotensive, tachycardia, tachypnea, significant blood loss, rapid blood loss, uncontrolled bleeding, or significant mechanism of injury. So let's talk about arterial bleed. So pressure causes blood to spurt, making bleeding difficult to control for arterial bleeds. With an arterial bleed, typically it'll be a brighter red, rich in oxygen, and spurts in time with the pulse. This decreases as the amount of blood circulating in the body drops, or the blood pressure starts to drop. The higher the blood pressure, the more it's going to spurt out. Venous bleeding is a dark red, low in oxygen blood, which flows slowly or rapidly depending on the size of the vein. A venous bleed does not spurt and is easier to manage, like applying pressure or whatnot, versus an arterial bleed where you got to apply pressure and we have to apply a tourniquet depending on how bad the arterial bleed is. More likely also to clot spontaneously than an arterial bleed as well. This is a capillary bleed. So capillary bleeds are bleeding from a damaged capillary vessel, and depending on where it's located, it can bleed quite a bit, depending on how vascular that area is. So like head bleeds can have a small little laceration and look like the person was murdered, right? Same thing with veins as well, like varicose veins. Those bleed like someone was stabbed. So with this capillary bleed, it'll be a dark red, which will ooze from the wound steadily but slowly, and more likely to clot spontaneously than an arterial bleed. So clotting, the clotting process, so bleeding tends to stop rather quickly within about 10 minutes in response to internal mechanisms and exposure to air. When the skin is broken, blood flows rapidly from the open vessel. The cut ends of the vessel begin to narrow, so vasoconstriction, reducing the amount of bleeding. Next, a clot forms, plugging the hole and sealing the injured portion of the blood vessel. This is called coagulation. Bleeding will never stop if a clot does not form unless the injured vessel is completely cut off from the main blood supply by direct pressure or a tourniquet. Right? And eventually it will stop when you have no more blood left in your system. So despite the efficiency of the circulatory system, it may fail in certain situations. Movement, disease, medications, removal of bandages, the external environment, body temperature, and severe injury. So let's talk about diseases potential. So hemophilia. Hemophilia is when the patient lacks one or more of the blood's clotting factors. There are several forms. Most are hereditary, but some are very severe. Bleeding may occur spontaneously as well. So all injuries, no matter how trivial, are potentially serious. The patient should be transported immediately. They have to receive special medications or factors they need to receive to help with that clotting factor so they don't bleed out and die. Internal bleeding is any bleeding in a cavity or space inside the body. So that could be like in your femurs, your lower legs, your abdomen, your chest, your lungs, anything like that that has vessels. This can be very serious, but because it's not easily detected, it can definitely cause more injury or damage to the internal organs. It can cause hypovolemic shock, which is why we need to pay attention to vital signs and do a good job inspecting the body, looking for any kind of bruising or ecchymosis, right? Looking at the mechanism of injury to see if there's potential for internal bleeding. So some possible conditions of internal bleeding include stomach ulcers, lacerated liver, ruptured spleen, broken bones, especially the ribs of the femur, and a pelvic fracture. Your femur, if you have a fracture and it hits an artery, your femur, the cavity there, can hold approximately 750 mLs of blood. So often, the only signs of internal bleeding are contusion or ecchymosis. The mechanism of injury, MOI, for internal bleeding, be like a high energy MOI should increase your index of suspicion for the possibility of a serious unseen injury. So again, looking at mechanism of injury and your index of suspicion may lead you to believe there could be potential for internal bleeding. And there are severe forces affected by the body, like penetrating trauma or blood trauma. Use the mnemonic DCAP BTLS to assess for signs of injury. Deformities, contusions, abrasions, punctures and penetrations, burns, tenderness, laceration, and swelling. The nature of illness for internal bleeding is not always caused by trauma. Possible non-traumatic causes include bleeding ulcers, bleeding from the colon, ruptured ectopic pregnancy, and aneurysms. These signs are frequent but not always present. Abdominal tenderness, guarding, rigidity, pain, and distension. You need to palpate the abdomen, right? You've got to look for that rigidity, right? Ask the patient about pain. Scale of 0 to 10, how do you rate your pain? Is there any abdominal distension? Is it hard and rigid and distended, right? Is there any guarding? Is he bringing his knees up to his stomach and kind of guarding the area? In older patients, signs also include dizziness, faintness, and weakness, so syncopal episode potential as well. Ulcers or other gastrointestinal problems may also cause vomiting of blood, bloody diarrhea, or urine. It is not as important for you to know the specific organ involved as it is to recognize that the patient is in shock and responded appropriately. So again, do your assessment, get vital signs, start doing your initial set and work on trending to make sure that the patient's heart rate isn't going up or down, blood pressure isn't going up or down, and kind of monitor that. Some signs and symptoms of internal bleeding, obviously the most common would be pain, swelling in the area of bleeding, distension, or bleeding into the chest cavity or lung, which may cause dyspnea, tachycardia, and hypotension, along with hemoptysis, which is bright red blood that is being coughed up, a hematoma, which is a mass of blood in the soft tissue beneath the skin, or bruising, which is a contusion or ecchymosis, which may not presently may be present initially. Bleeding from any body opening, bright red bleeding from the mouth or rectum, hematuria, which is blood in the urine, non-menstrual vaginal bleeding, hematemesis, which is vomiting blood. Now, it could be bright red or dark red. It also could have a coffee ground appearance. Melena, which is a black, foul-smelling, tarry stool with digested blood. Pain, tenderness, bruising, guarding, or swelling. Possible closed fracture. Broken ribs, bruises all over the body of the chest, bruises over the lower part of the chest, or a rigid distended abdomen, which will indicate possible lacerated spleen or liver. Hypoperfusion or hypovolemic shock. You'll start seeing a change in mental status due to the hypoxia. Patient will be very anxious, restless, and combative, because now they're lacking perfusion. Weakness, faintness, and dizziness on standing, which is why you want to get orthostatic blood pressures in patients you think that are dehydrated or potential could have a low volume. So you take a blood pressure lying down, sitting up, and standing at 2-minute intervals. Late signs of hypoperfusion suggest internal bleeding include tachycardia, weakness, fainting, or dizziness at rest, thirst, nausea and vomiting, cold, moist, clammy skin, and shallow, rapid respirations. Dull eyes, slightly dilated pupils that are slow to respond to light, capillary refill of more than 2 seconds in infants and in children, weak, rapid, thready pulse, decreasing blood pressure, altered level of consciousness as well. Patients with these signs and symptoms require prompt transport. I know there's a lot there, but if they have anything that's indicative of internal bleeding, we need to make sure that's getting treated. And the hospital has the equipment to be able to handle that. So as far as scene safety goes, again, be alert. At vehicle crashes, ensure absence of leaking fuels or energized electrical lines. In violent incidents, make sure police are on the scene and they've cleared the scene for safety. You're going to follow standard precautions. The mechanism of injury or nature of illness, we're going to determine the MOI or NOI. We're going to consider the need for spinal mobilization, additional resources. And we're going to consider environmental factors such as weather. So if they have significant bleeding and need to get to a trauma center, and the weather is nice, and there's going to be a prolonged extrication, maybe we start considering flight medicine. So do your primary assessment. Do not be distracted from identifying life threats. Form a general impression. Note important indicators that alert you to the seriousness of the patient's condition. We need you to be aware of obvious signs of injury and distress, such as facial grimace. So again, look at the patient. Let's see how they're presenting to you. As you're palpating, see if the facial expressions change. Determine the patient's gender and age, right? Give a rough idea, rough estimate if you can't speak with them. Perform a rapid exam. Remember, it's head to toe, no more than 60 to 90 seconds. Looking for life threats. If you see a life threat, treat it. So femur fractures, pelvic fractures, sucking chest wounds, things that are going to cause the patient to die rapidly if something is not done right away. Assess your skin color and determine level of consciousness using the APFU scale. Maybe look at airway and breathing. It's the same as we always have had. Consider the need for spinal. Ensure a patent airway. Look for adequate breathing. Remember, rate, rhythm, and quality equal rise and fall. Right? Check for breath sounds. If you have absent or decreased breath sounds on one side, it potentially could be a pneumothorax. Provide high flow oxygen and assist ventilations with a BVM or bag valve mask or a non-rebreather mask. We're going to insert an oral pharyngeal airway if they do not have a gag reflex to see if the airway, to secure the airway if the patient is unconscious. So if they are unconscious and they have a gag reflex, we cannot put an oral pharyngeal airway or OPA in place. Right? If they have no head trauma or any potential for a basilar skull fracture, right? We're going to look for battle signs behind the ears, right? Then at that point in time, we can put a nasal pharyngeal airway in place. We're going to assess circulation by assessing the pulse rate, rhythm, and quality. We're going to determine skin condition, color, and temperature. Again, looking for signs of shock. We're going to check capillary refill time, control any external bleeding. If you have a significant bleed, tourniquet and move forward. Don't spend all your time trying to control a bleed by holding pressure when other things have to get done. Tourniquet and move. We're going to treat for shock by applying oxygen, maintaining the normal body temperature, and improve circulation. At this point in time, we need to make a transport decision. So assessment of the ABCs and life threats will determine the transport priority, whether it be a 1, 2, or a 3. Patients who may have significant bleeding will quickly become unstable if the bleeding is not controlled. The signs of that will imply the need for rapid transport: tachycardia, tachypnea, low blood pressure, weak pulse, and clammy skin. We then want to do some history taking, investigating the chief complaint, looking for signs or symptoms of the injuries due to the MOI or NOI. We're going to note obvious signs of internal bleeding. Look more carefully at this step. Try to find it. Okay? Palpate, look, inspect, right, before we start doing everything else. In a responsive trauma patient who has isolated injury for a limited MOI, Consider a focused assessment before assessing vital signs and obtaining a history. Assess the entire patient, looking for a source of problem, pre-existing illnesses, and other issues. Remember I said you can't be naked unless you're trauma naked on a trauma call? You've got to cut their clothes off. Now, can you keep the underwear intact? Absolutely. Okay, on a female, or even a male. But you have to inspect and look for fractures, lacerations, or signs of shock. Do a sample history. Ask the patient about blood thinning medication. That's going to be an important finding for you. Are they on blood thinners? The patient is unresponsive. Obtain the history information from medical alert tags or bystanders. Look for signs and symptoms of shock and determine how much blood has been lost. We're going to do our secondary assessment by recording vitals. We're going to complete a focused assessment of pain. We're going to attach appropriate monitoring devices. And with a critically injured patient or a short transport time, there may not be time to conduct a full secondary assessment. Our goal is to get them to definitive care following the golden hour, right? We're going to assess all areas for decap BTLS to the head. Look for uncontrolled bleeding from large scalp lacerations. The abdomen. We're going to feel all four quadrants for tenderness and rigidity. And with the extremities, we're going to record the pulse, motor, and sensory functions. Make sure they still have feeling, they still have circulation as well. We're then going to assess vital signs. We're going to assess a baseline set to observe the changes that may occur during transport. A systolic blood pressure of less than 100 with a weak, rapid pulse, which suggests presence of hypoperfusion. Cool, moist skin that is pale or gray is an important sign because they are not being perfused appropriately. In geriatric patients and patients who are taking certain blood pressure medications, the pulse rate may not increase with early shock. Patients that are on like metoprolol, that's a beta blocker that's going to control heart rate, even though it's there for blood pressure. We try to determine the patient's baseline blood pressure and quickly obtain a medical history list of the medications. We're then going to provide a reassessment, number 5 for stable, 15 for unstable. Remember that children will compensate well for blood loss and then they crash quickly. So you need to pick up on that compensation. As far as interventions go, with significant bleeding, provide high flow oxygen, control any external bleeding that needs to be controlled, whether it be done by pressure, tourniquet. If a bleeding is suspected, apply high flow oxygen by a non-rebreather mask to provide rapid transport. Do not delay transport of a patient to complete an assessment. Get them in the back of the truck and start transporting. Communication and documentation, we're going to recognize an estimate and report the amount of blood loss and how rapidly or over what period of time it occurred. We're going to communicate all relevant information to the staff of the receiving hospital. Communicate your findings, any interventions used, and document all injuries, the care provided, and the patient's response. Remember that anytime you do a procedure, you have to have something done pre and post. So we're going to follow standard precautions, apply high flow oxygen, and if obvious life threats and bleeding are present, control them. If it's bleeding, stop the bleeding. All right? That's what we need to focus on. We're going to apply direct pressure. If direct pressure doesn't work, we need to go to a tourniquet. We need to move forward. We can't put all of our time and effort into working on the patient's arterial bleed if we can just tourniquet it off and move forward. So direct pressure is the most effective way to control bleeding. Remember to use your 4x4s. The way the mesh is set up with 4x4s, it actually helps trap and promote more clotting. Apply pressure with the above fingertip over the top of the sterile dressing. For an object protruding from the wound, You're going to apply a bulky dressing to stabilize the wound in place and apply pressure the best you can. Never remove an impaled object from a wound unless it is in the cheek or blocking a patient's airway. We're going to hold the uninterrupted pressure for at least 5 minutes, right? And then we're going to follow skill drills to control the external bleeding with direct pressure. So when you come in on one of your off days or in-person days, we're going to go over how to place direct pressure, tourniquet use, and all that stuff there. Pressure dressings. So for that, we're going to firmly wrap a sterile self-adhesive roller bandage around the entire wound, using 4x4 sterile gauze pads for small wounds and sterile universal dressings for larger wounds, like the abdominal pads and trauma dressings that they have out there. Cover the entire dressing below and above the wound with pressure. So obviously, it's called the pressure dressing. We're going to stretch the bandage tight enough to control bleeding, but you should still be able to palpate a distal pulse on the injured extremity after applying the dressing. It's going to be there for a while. We're going to make sure they don't lose any pulses at all. If necessary, you want to add more dressing over the first. Bleeding will almost always stop when the pressure of the dressing exceeds the arterial pressure coming out. All right, so a little bit about hemostatic agents. Any chemical compound that slows or stops bleeding by assisting with clot formation. There's two forms. There's a granular powder, which can be inserted into a small wound and create a tight seal, or a gauze, which is impregnated with a clay substance. Right? Most places have the gauze pad that you put into it. Right? It can be used together with direct pressure when direct pressure alone isn't effective. And the use of a hemostatic agent, EMS, remains largely experimental. Right? A lot of states are switching over to it, though. And be aware of the following local protocols. All right, so for tourniquets, we're going to go over the skill drill on one of your days when you come in and how to apply a tourniquet. There are different types that are out there. If a commercial tourniquet is not available, you can create a tourniquet using a triangular bandage and a stick or a rod. Right, so I'm going to, sorry about that. So we take it, fold it, take a stick or a rod through it, and we just turn, and turn until the bleeding stops. And then we secure it at one of the ends that are hanging out. Again, I'll show you guys how to do that on one of your practical days. When you apply a tourniquet, make sure you observe the following precautions. Do not apply it directly over a joint. Always place a tourniquet proximal to the injury. Make sure the tourniquet is tightened securely. And never use wire, rope, or a belt of any other narrow material because it could cut into the skin. We're then going to place a padding around the tourniquet. We're never going to cover a tourniquet with a bandage. Over there, it can be taken off. We also need to mark the time it was used. Once it is on, please do not take it off. Let the hospital take care of that. All right, so splinting. Splints work well to stabilize bleeds. Air splints, also known as a soft or pressure splint, can control internal bleeding and external bleeding associated with severe extremity injuries, as you can see in the picture here. So with this, splints immobilizes fractures, acts as a pressure dressing applied to an entirely extremity rather than to a small local area. And please use only approved, clean, or disposable valve stems when orally inflating or an air splint. All right, almost done here. Rigid splints will help immobilize fractures, reduce pain, and prevent further damage to soft tissue injuries. We are going to go over splinting on one of your in-person days. Once the splint is applied, monitor pulse and motor and sensory function. in the distal extremity. All right, bleeding from the nose, ears, and mouth. Bleeding around the face presents a risk for airway obstruction or aspiration. All right, so there are several conditions that can result in bleeding for the nose, ears, and mouth, including the following: skull fractures, facial injuries, sinusitis infection, or the abuse of nose drops, dried or cracked nasal mucosa, and other abnormalities like high blood pressure, coagulation disorders, and digital trauma from nose picking. Right, I've been to a couple residences just working here where I've gone there and they've had significant nosebleeds, took their blood pressure, and their blood pressure was very hypertensive. Right, but you still want to ask the questions, and you hit your face or your nose. You use any recreational drugs? You snort anything? Right, you got to ask these questions to find out if that's truly what's going on or what caused the bleed. Right, they may or may not answer you, but usually if they're hypertensive and they have a nosebleed, it's because their blood pressure has been out of control for a long time. So another name for nosebleed is called epistaxis, which is a common emergency. Occasionally it can cause enough blood that leads to shock. You can have that bad of a nosebleed. The blood that you see may only be a small part of the total blood loss. It only takes about a tablespoon of blood into your stomach to actually trigger a vomiting reaction. So you want to make sure you protect the airway. The person who swallows a lot of blood may become nauseated and, like I said, start vomiting. Bleeding from the nose or ears following a head injury may indicate a skull fracture. And I'm going to show you guys in the next picture. Do not attempt to stop the blood flow. Applying excess pressure to the injury may force blood leaking through the ears and nose to collect within the head, which we don't want. It's exiting for a reason. This could increase the pressure on the brain and possibly cause permanent damage. If you suspect a skull fracture, lightly cover the bleeding site with a sterile gauze and pad to collect the blood and keep the contaminants away from the site. So the next pair here, you notice the target blood here, and then you see the yellow staining on the outside, right? That yellow staining on the outside of that picture there is cerebral spinal fluid. And the target or halo-shaped stain may occur on the dressing. Now, I'm not saying wait there and try to collect the blood. Take care of your treatments first. If you have time at the end to collect it, then do it. Emergency medical care for bleeding would be controlling internal bleeding or bleeding from major organs. Usually requires surgery. That's why I mentioned before, if you have the need for air medical transport, where the definitive care is where it can meet surgical needs, not just an emergency department, but an ER that can provide a surgical suite to take care of that patient. But our job is to make sure we keep the patient calm, reassured, and as still and quiet as possible by providing high flow oxygen, maintaining body temperature. We're going to splint the injured extremity, usually with an air splint if we have one available. Never use a tourniquet to control bleeding from a closed internal or a soft tissue injury. Right. If you have a chest bleed or a neck bleed, please do not put the tourniquet around the neck. All right, that would just lead to a lot of bad publicity, and you're probably end up killing off your patient. All right. So other than that, let's get into the review. Which of the following is not a component of the cardiovascular system? What do we got? A, B, C, or D? Let's see, you guys still there? There we go. Right. So Actually, the answer is B. Components of the cardiovascular system include the heart, blood vessels. The lungs are a component of the respiratory system, so different system. So which of the following is not a component? Heart, lungs, venules, plasma. So the component would be the lungs itself. Yes, Nick, you are right though. But they need oxygenation, right? They oxygenate the blood, but they're not part of the cardiovascular. They work hand in hand with it, but the lungs are actually considered part of the respiratory system.
Got it. That makes sense. Yeah.
Yep.
Thanks.
Yep. Perfusion is the most accurately defined as. Perfusion is most accurately defined as. All right, C it is. Number 5, a man involved in a motorcycle crash has multiple abrasions and lacerations. Which of the following injuries has the highest treatment priority?
B.
All right. So the highest treatment priority. So pinkish ooze, dark red flowing, forearm with debris, or spurting blood. Let's go with D. Arterial bleeds can make a patient bleed out very, very quickly. Number 4, which of the following sets of vital signs is least indicative of internal bleeding? They went with A. Internal hemorrhage typically reveals vital signs that are consistent with shock, hypotension, tachycardia, tachypnea, hypertension, bradycardia, and low respirations. Choice A is consistent with a closed head injury, not an internal bleed. When caring for a patient with internal bleeding, the EMT must first
C.
So you would think that, or maybe ensure a patent airway. This is one of the registry questions. What is D? Take appropriate standard precautions, gloves and mask, right? Eye protection, basic precautions. The answer is D. It's going to try to get you because it wants you to go back and say, oh, ensure a patent airway. Got it. ABCs come first, but before that, you have to have standard precautions. You have to have your gloves on. So that's where the National Registry will get you, is what's most appropriate. And you can't treat your patient without wearing gloves. The quickest and most effective way to control external bleeding from an extremity is
D.
You got B, direct pressure. Direct pressure. Number 7, when applying a tourniquet to an amputated arm, the EMT should
B.
All right, B it is. Number 8, a 70-year-old man is experiencing a severe nosebleed. When you arrive, you find him leaning over a basin which contains an impressive amount of blood. He has a history of coronary artery disease, diabetes, and migraine headaches. His BP is 180/100. His heart rate is 100 beats per minute. Which of the following is most likely contributing factor to his nosebleed? All right. Blood pressure. Number 9, when caring for a patient with severe epistaxis, the most effective way to prevent aspiration of blood is to do what? You don't want them swallowing it, right? So the old tales of tipping the head back, okay, is wrong. Lean them forward and let the blood flow until it clots. One of the best tricks you can utilize is taking an ice pack and putting it over the bridge of the nose to help vasoconstriction. Controlling internal bleeding requires
B.
B, surgical intervention. Exactly. All right, let me just turn off the recording here.